Okay, September 15, that's today. So 1 to 4, 1 to 3, 1 to 3:30. Okay, I'll be your facilitator. My name is Reynaldo Ojoson. Just to introduce myself, I am a retired professor from the UP College of Medicine. I was forced to retire because of my age, 65. Now that was in 2014. So 9 years after, I'm still connected with the UP College of Medicine as a professor without compensation. Okay, so just a outreach to teach you guys. Okay, so the mentees are the following. Okay, anyway, you have your names on your screen later. On your screen, I'll get to know you more later on. Okay. So actually, this was the learning objectives given to me in the past. Okay, I don't know whether this still holds true. Okay, so have you seen this before, Charlene?
No po, Doc.
Oh, sige. So, sige, we'll try to make the best out of it. So, demonstrate and apply principles and approaches in the diagnosis and management of common OPD surgical diseases. You're now in the OPD, right? OPD?
Doc, we're still under OS 217, so this is actually about our first few encounters pa po with the surgery department.
Okay. So, but you, LU5 kayo, di ba?
Yes po.
OPD year po namin.
OPD year ninyo. So you'll be exposed to patients already. You'll be seeing patients in the OPD department, right?
It's Doc.
Okay. So common OPD surgical diseases. So perform a focus history. Okay. When you say focus, just the relevant ones, no? Okay. And then perform a focus physical examination. That's why I decided to share with you my patient management process, because it's a focus diagnostic as well as therapeutic process. Okay, focus history and focus physical examination, and then use and interpret diagnostic procedures, results, and formulate the management plan. So these are the general learning objectives. Okay, so we'll just stick to that. So for today, we'll be talking on anterior neck mass, right? Okay. So since you don't have an official copy, I'll just make it this way to simplify things. Given the patient, so you were given the patient, the thyroid patient, the mentees present the case and discuss the clinical management using the rational and cost-effective processes. So this is the patient management process that I showed you. All of you have seen the video? Yes or no?
Yes po, Doc.
Okay. The lecture on patient management process and overview. So it jives with our learning objective, which is to do a focus, history and physical examination, and everything will be rationalized in terms of treatment processes, diagnostic processes. So this is actually the one that I am using now, the framework. I've been using this since 1990s up to now. Okay. So the essentials in the learning objectives will be your history and PE, primary working impression, and differentials. Okay. In the differentials, I just require you to give two, at least two, just two, okay, or at most three. Okay. Plan of management, diagnostic and preparation, plan of treat management in terms of therapeutics if it's not surgical or surgery, and then post-op complications, prognosis, and surveillance. Okay. So actually, these are the things that I got from the. I don't know whether it's still it has been revised or not. No, but when I see your evaluation sheet today, it seems there's some some modifications already. So we'll be the patient management process will be focusing on the history and physical examination, differential diagnosis, aside to the primary and secondary diagnosis, and then diagnostics and treatment plan. Okay. So here I would, aside from presenting the case, you will be presenting the case. By the way, I just got the your case this morning, so but I just have a chance to have a glimpse of it. Okay. Active participation, and then I will give you an online learning evaluation test exercise in which you will answer sort of a exercise. It's not really a test, but it's an exercise in which you try to recall what were taken up in the patient management process, as well as or pick up something from the case presentation itself. Okay. So this is the one that was given to me. Now I will try to follow it, but basically we will be focusing on this case management. No? Okay. Presentation of a problem list in order of priority, develop a plan that would confirm the initial diagnosis, rule out the differentials, and then pharmacologic and then non-pharmacologic modalities. Is this a new one that you got hold of? Hindi nyo alam.
Yes po, Doc. May copy po kami nito.
Pero bago ito, you
Ah.
don't know.
Hindi po namin sure if bago po.
Anyway, so we will be focusing on this, but we will try to integrate this one, data analysis. Now, kasi when you're in the clinics, you're actually seeing patients already. So dapat focus yung ano ninyo, no? So whenever you come out with diagnosis, no? So you have to collect the data also. Then when you come out with the differentials, and then yung mga iba, then you have to invoke yung mga pathophysiologic correlation, no, to explain the diagnosis, the basis, no? Okay. Okay. So, sige, I'll try to follow this in the scoring, no? Okay.
May ano po, Doc, followed po yung format na binigay niyo po.
Yeah, I saw it. I'm glad that you did, no? Because you won't regret it, I assure you. Okay?
Thank you po.
Sige. Okay, so what I'm going to do is that I'll let you present the case because I didn't read the whole thing. I just got it about an hour or two. The resident monitor just gave it to me this morning. No, okay. So I'll just listen to your presentation, and then after that, during your presentation, I will jot down questions now, but I won't ask them right away to save time. I will ask the questions later on after your presentation. Now, by the way, you had a journal critic, right?
Yes po, Doc.
Strictly speaking, di yata kasama doon, di ba? Kasama ba?
Sa criteria po ba?
Yes, yung sa expectations, wala, no?
Wala po.
Okay.
But we did na lang po sa may
Sige.
ilalim po.
So, because the instructions that I gave you was probably copied from the instructions I gave the LU5. No? In the LU5, there is a journal critic. No? Anyway, you did it already, di ba? So, isasama na natin. Okay.
Yes po, Doc.
Okay. Sige. So, we can start the case presentation. No? Kayo na magsalita. No? Okay. So, sino moderator? Si Charlene? Ikaw?
Yes po, Doc. Okay po. I'll share my screen po. Can anyone see my screen na?
Yeah.
Okay.
Yeah.
Okay. So for this presentation po, we divided it among ourselves po, but everyone po help in each part naman po for the diagnostic, therapy, and everything po. Okay, so to start our discussion, today po pala, we will be presenting a case on a patient with a chief complaint of anterior neck mass. So to start our discussion, let us first present the patient's database. So now, can anyone discuss the health history and physical examination of the patient?
Hello, I can continue the discussion. Let's start it off.
Okay. wait, sorry.
Okay, good. So let's now present the present database. So we're dealing with a patient named BS. She is a 54-year-old female and a Filipino factory worker from Cavite. She presents with a chief complaint of anterior neck mass, of which we know started 6 months ago, gradually progressing and is associated with intermittent pain. Okay, next. So more on that on the history of the present illness. So 6 months prior to consult, she noted a gradually enlarging anterior neck mass. There was no fever, dysphagia, weight changes, or heat and cold intolerance. So emphasis on these 2 points. She obtained an ultrasound on initial consult. In the interim, further enlargement and intermittent pain was noted, partial relief with paracetamol, and the persistence of these symptoms prompted the present consult. So the thyroid sonography showed that both lobes of the thyroid were normal in size and that the parenchyma were also normal in echogenicity except for an oval hypoechoic mass with incomplete peripheral rim calcifications, the mass measuring 3 by 1.5 by 2 centimeters, located in the superior right lobe. Furthermore, there was minimal peripheral and central vascularity seen in color flow. There was no solid or cystic mass in the other lobe, the left lobe, and the vasculature, the trachea, the esophagus, and the strap muscles were also normal. Important to note is that there is also no enlarged cervical lymph nodes. And lastly, the parotid and the submandibular glands were symmetrical in size and echogenicity. So this gives us the ultrasound impression of a hypoechoic mass with incomplete peripheral calcifications in the right lobe of the thyroid gland, having a TRADS category 4 for moderately suspicious. Okay, so past medical history revealed that the patient was hypertensive, maintained in with amlodipine, no previous surgeries. Family history revealed goiter in the mother and the sister, and hypertension in her parents. Personal social history shows that she wasn't a smoker, not an alcoholic, and of course was a factory worker.
So before I proceed to the physical examination findings, I just like to clarify na this case pala was a paper case, so we were not able to personally assess the patient. So this was just a paper case given to us. So for the physical example, okay, the patient was awake, conversant, and not in distress. The patient's vital signs are within normal limits except for the blood pressure, which can be classified as stage 1 hypertension. The patient has an icteric sclerae, pink palpebral conjunctiva, and patient has 4 by 4 centimeters anterior neck mass at the right, and it was characterized as doughy, movable, non-tender, no skin changes, and it moves with deglutition. And patient has no cervical lymphadenopathy. Patient has equal chest expansion, clear breath sounds, a dynamic precordium, distinct heart sounds, normal rate and regular rhythm. The abdomen is not distended, it is soft, non-tender, no palpable mass, and patient has full and equal pulses, pink nail beds, and no edema. So now that we have already presented the health history and the physical examination of the patient, we can now move on to the case management discussion. So we will start first by formulating our clinical diagnosis. So using the data from our database, we will use them as cues to come up with our primary and secondary clinical diagnosis. So we will also take into account yung pattern, yung prevalence, and pathophysiology of the diseases. Okay. So starting for the primary clinical diagnosis, we chose simple goiter as our primary. Rule in because the patient has gradually enlarging anterior neck mass. The mass moves with deglutition and without any skin changes. Patient is a female and a 54-year-old, and she has a family history of goiter. And rule out because the patient does not have any symptoms of signs and symptoms of hypo and hyperglycemia, such as there's no weight changes, heat and cold intolerance, The patient has normal vital signs, and the mass is movable. On the other hand, for the secondary clinical diagnosis, we chose thyroid carcinoma because patient has a progressive anterior neck mass growth at the right for 6 months. It was measured as 4 by 4 centimeters mass with associated intermittent pain. Patient is also a factory worker in which she probably had industrial exposure to chemicals. And patient also has a family history of goiter, in which, according to studies, that those with family histories of multinodular goiter are at increased risk of thyroid malignancy. And patient also has no signs and symptoms of hypo or hyperthyroidism. On the other hand, it is less likely because, according to the CPG guidelines, the patient is neither less than 14 years old or 70 years old. Patient is not a male, and she does not have any recent hoarseness, dysphagia, dyspnea, weight changes. And patient has no family history of thyroid carcinoma and other cancers. And for the neck mass growth, it was not rapid. Patient did not have any previous head or neck irradiation, no cervical lymphadenopathy, no inherited genetic syndromes associated with thyroid cancer, and the mass was described as movable and doughy. Now, to further support our diagnosis, can anyone discuss the pattern, prevalence, and the pathophysiology of the diseases we mentioned?
I can go with that part.
Okay, thank you, Sean.
Okay, so again, the primary clinical diagnosis is simple goiter. So let's look at the pattern, prevalence, and pathophysiology of goiter. So for the pattern, let's look first at the anatomic pattern that can give us clues on the possible diagnosis for the patient. So the case describes the chief complaint of the patient as a gradually enlarging anterior neck mass, more prominent on the right, and initially appeared as a marble-sized mass. So based on this given information, it can be inferred that the area where the mass is observed is also consistent with the anatomic location of the thyroid gland. So the thyroid gland is a butterfly-shaped organ that is located in the middle of the neck. So when thyroid lobes enlarge, they usually bulge outward since they are situated at the anterolateral portion of the trachea, and they are covered only by the thin strap muscles, subcutaneous tissue, and skin, which provide very low resistance. So because of this outward growth, the trachea and esophagus, which are located posterior to the thyroid gland, are usually not compressed. So this explains why patients with small goiter generally do not present with dysphagia and respiratory distress, which is also what the patient did not manifest. So next slide. So in terms of clinical patterns, so majority of patients with goiter are asymptomatic, since goiters have a very slow growth that may span over several decades. And thus, small goiters rarely prompt consult and are usually observed first during physical examination or during imaging procedures as incidental findings. So intermittent pain in the patient suggests the possibility of hemorrhage into a nodule, which might eventually lead to a sudden thyroid enlargement, which we still do not see in the patient. So the absence of fever, weight changes, heat or cold intolerance, edema, and normal vital signs of the patient highly indicate that there is an absence of either hyperthyroidism or hypothyroidism. And then the movement of the mass upon deglutition is typical of thyroid masses such as goiter, and this supports the our primary working impression. And then the absence of any cervical lymphadenopathy suggests but does not confirm a non-malignant etiology of thyroid enlargement. And on another note, the asymmetric enlargement of the mass with the right side growing larger than the left suggests a nodular type of goiter, but we still need imaging for this to be confirmed. So next slide. So in terms of prevalence, the most recent estimates indicate that the prevalence of thyroid function disorders in the Philippines stands at 8.53% among the adults. Among these thyroid disorders, goiter is the most common with a prevalence rate of 10.12%. So iodine deficiency is actually the most common cause of goiter in the world, particularly in the country. And due to the slow growth of goiters, they are most often found during the 5th and 6th decades of life. And take note that our patient is a 54-year-old. And then they are also more often seen in women than in men. And in fact, females are approximately 4 times more likely to develop goiter in comparison to females. And then let's take note that the patient here is a female. There's also a possibility that the patient is exposed to goitrogens through her occupation or diet, but we don't have information regarding that since we did not personally evaluate the patient. And meanwhile, ethnicity appears to play an insignificant role in the prevalence of goiter based on current literature. And next slide. So to sum it all up, let's look at the pathophysiology of goiter. So the thyroid gland is an endocrine organ that is controlled by the thyroid stimulating hormone, which is also called TSH or thyrotropin. And this is released by the pituitary gland. The latter, meanwhile, is controlled by the thyrotropin releasing hormone or TRH, which is secreted by the thalamus. So the thyroid gland produces the thyroid hormones T3 and T4, which play central roles in regulating metabolism, growth, and development. So high levels of thyroid hormones send a negative feedback to the hypothalamus and the pituitary gland to halt the further release of TRH and TSH respectively. And the synthesis of these thyroid hormones requires iodine, which is obtained from the diet and absorbed by the thyroid cells upon intake. So thyroglobulin is a substance produced by thyroid cells, and this thyroglobulin must be iodinated first in order to form T3 and T4. Thus, when it is expected that when there is iodine deficiency, thyroid hormone production decreases. And consequently, low levels of thyroid hormones release the hypothalamus and pituitary gland from negative feedback inhibition and cause them to secrete TRH and TSH respectively. And this stimulates the thyroid gland to undergo enlargement or hyperplasia, manifesting as goiter. So this process is actually a physiologic compensatory mechanism that enables the thyroid gland to capture and store as much iodine as possible and maintain the synthesis of thyroid hormones. Synthesis of thyroid hormones. Meanwhile, on another note, again, the family history of goiter of the patient suggests a genetic component of the disease and or similar exposure of the family members to environmental risk factors.
Okay, so let's now proceed to our secondary clinical diagnosis, which is thyroid carcinoma. So this presents a complex epidemiological profile, and it's influenced by numerous factors. And in the Philippines, there has been a significant recent increase in thyroid carcinoma incidence, specifically 7.3 per 100,000 Filipino males and 17.3 per 100,000 Filipino females, making it the most common cancer among females. But this rise is partly due to heightened awareness, improved healthcare access, and enhanced diagnostics na nag-lead to the detection of previously undiagnosed cases. So next slide, please. Some of the risk factors encompassing gender. Females are more vulnerable. Age, which is more common in individuals over 40 years old. Exposure to ionizing radiation, family history of thyroid cancer, hereditary syndromes, and pre-existing thyroid conditions like goiter and or nodules. So besides genetics, urbanization has also contributed to this increase, and Cavite, where our patient lives, is a continuously urbanizing area, and this is linked to changes in diet, higher exposure to potential carcinogens, and better access to early diagnosis through healthcare facilities. And while factory work, which is yung trabaho ng patient natin itself, isn't usually a direct risk factor for developing thyroid carcinoma. Certain aspects of the job, such as yung possible exposure to chemicals, radiation, shift work, stress, and yung environmental factors could indirectly elevate the risk factor for this patient to develop thyroid cancer. And side note, September is also Thyroid Cancer Awareness Month. And so, yeah, that's this month. So next slide, please. Ayun, so we consider thyroid carcinoma as a possible diagnosis because of the 4x4 cm mass growth on the right side of the neck ng patient, the intermittent neck pain and family history of goiter, but no family history of thyroid or cancer. And thyroid carcinoma may manifest as a painless thyroid nodule or neck mass, which can be palpable and firm. However, sa patient natin, it presented with a movable doughy mass, while thyroid cancer often fixed siya and immobile upon palpation. And thyroid carcinoma may lead to voice changes or hoarseness if it affects yung vocal cords. And pag advanced na yung cases, it can cause difficulty swallowing and or breathing, which are not yet present in our patient. And thyroid function changes like hyperthyroidism or hypothyroidism can occur, but not really universal. And many cases of thyroid carcinoma do not significantly impact thyroid function. And there's also no cervical lymph adenopathy present in the patient. And that's why early diagnosis and evaluation often involving imaging and fine needle aspiration biopsy, which will be further discussed down the line of the presentation, are crucial for accurate assessment and management of thyroid carcinoma. Lastly, short pathophysiology lang. Thyroid carcinoma results from genetic mutations in thyroid follicular cells with BRAF and RAS mutations that are commonly leading to uncontrolled cell growth and then tumor formation. And in the Philippines, yung papillary thyroid carcinoma is prevalent and it's often linked to BRAF V600E mutations. And while it's generally slow growing, yung variable pathology is what complicates diagnosis, and it necessitates a pattern recognition and algorithms sa histopathology. And so enhanced epidemiological surveillance and genetic research are vital for understanding thyroid carcinoma's complex causes, improving risk assessment, early detection, and of course, customized patient management. So those are our primary and secondary clinical diagnoses, sa goiter and thyroid carcinoma, respectively. So let's proceed to paraclinical diagnosis. Thanks.
Okay. So now that we have identified our primary and secondary clinical diagnosis, we would decide whether there is a need to perform a paraclinical diagnostic procedure. So next slide. This table shows the degree of certainty and the treatment modality to be used for our primary and secondary diagnosis. So based on the symptoms from the history, signs from the physical exam, and prevalence studies, we are 70% certain that the patient has goiter and 60% certain of thyroid carcinoma. So the only difference is that goiter is more prevalent than thyroid carcinoma. And the cutoff range for being certain is 60 to less than 90%. Thus, itong 70 and 60%, we could say now we are not certain of the diagnosis. So in addition, the treatment modality for our primary and secondary clinical diagnosis is different. So this would urge the need to perform a paraclinical diagnostic procedure. So is a paraclinical diagnostic procedure needed? Yes, because we are uncertain on the primary and secondary clinical diagnosis, and treatment plans are different. Okay, next slide, please.
Okay, and then in selecting the paraclinical diagnostic procedure to be performed, we listed down various options for the patient, and we let him or her choose, well, for this case, her choose the most cost-effective method and come up with a shared agreement. So we do this by comparing the procedures based on benefit, risk, cost, and availability. So the tests we listed down are the diagnostic and preoperative workup recommended in the 2021 CPG for thyroid cancer when we're suspecting malignancy in the thyroid. So usually these tests are done, parang it's included in an algorithm. So first we test the serum TSH, and then based on the results, we check what to do next. But then we listed down which test would be the most cost effective for arriving at a diagnosis for the patient. So going through the table quickly, first is the serum TSH and T4 measurement. So the benefit for this would be it would be to determine the thyroid function of the patient and the need for further testing. So if we need to do a scan or other things pa, or we have to parang continue monitoring the patient na lang. And then the risk for this is low risk naman since you just get blood. So it's acceptable. And then for the cost, for this whole table, the cost we listed down, you weren't able to get a source that indicates the cost for all tests within the Philippines. So we just listed down a range of the possible costs that the patient would have to cover if ever they take the test in different within the Philippines. So from the most from the cheapest option we saw to the most expensive one. And then for serum TSH and T4 measurement, it's widely available in the hospitals and diagnostic centers in the Philippines. So there. And then the next test would be the radionuclide thyroid scan, which is used to determine whether or not the nodule is hyperfunctioning or not. So again, this test would help us move along the algorithm of whether or not we have to have additional tests. So the risk for this one is acceptable, although since it exposes the patient to the radionuclide thyroid scan exposes patient to radiation. It's not usually recommended for patients who are pregnant. And then the cost we found to be between 2,000 and 5,000, or could be more. And it's not as available as the other tests we found in the Philippines.
So next is yung neck ultrasound. So for the benefits of this procedure, it is non-invasive, and it is a way to assess risk stratification through nodule size, location, presence of suspicious features, and presence of lymph nodes. And is also little to no risk in doing this test, so acceptable siya. And the price ranges from 2,000 or more. And it is available in most hospitals in the Philippines. And last is yung fine needle aspiration biopsy. So it determines cytologic features of the mass, and it is quicker, less painful, and invasive compared to other biopsy methods. And it is also acceptable. Yung risk lang is no tissue architecture is seen, and it fails to detect some of the important diagnostic and prognostic parameters. And of course, may risk of bleeding at the biopsy site, infection, and damage to structures near the thyroid. For a price range, nakita namin 500 pesos daw siya in government hospitals, but it could be more. But compared to other procedures, it is economical. Kasi it can also be done by palpation or ultrasound. And it is widely available in the Philippines, even in resource-limited settings. So the question here, which is the most cost-effective procedure? So we identified FNAB, or fine needle aspiration biopsy, is the most cost-effective diagnostic procedure of choice in confirming thyroid malignancy due to its accuracy and cost-effectiveness price.
And since you chose this, we'll have a quick rundown lang of what it entails. So FNAB, or fine needle aspiration biopsy, is used to evaluate thyroid masses with or without ultrasound guidance, as you mentioned earlier. So it uses a 23 gauge needle, and then several passes are made through the mass while aspirating the syringe, and then after that, the needle is withdrawn and the cells are collected and placed in a pre-labeled dry glass and then immersed in 70% alcohol solution, and while others are dried also. So several samples yung ginagamit. And then a sample of the aspirate is also placed in a 90% alcohol solution. And stains used are Papa Nicolaus or Wrights, and then examined under the microscope. So if there's a bloody aspirate, when we obtain bloody aspirates, the patient should be repositioned in a more upright position, and the biopsy repeated with a finer needle, so maybe a 25 or a 30 gauge needle. And then after the FNAB, the majority of nodules can be classified into several categories using the Bethesda system for reporting thyroid cytopathology. So if we do find na either malignant or benign yung mass, or if hindi satisfactory yung results, we find it out after, and yeah, we determine the risk of malignancy and further management. So each category has an implied cancer risk that ranges from 0 to 3% for the benign category to 97 to 99% for the malignant category. So we chose this since it really helps with choosing how to manage the patient after. And the next slide, please. So for our patient, though, we only had the neck ultrasound as pre-op result. So the results for the ultrasound would be that both lobes of the thyroid gland are normal in size and parenchymal echogenicity. There is an oval hypoechoic mass with incomplete peripheral rim calcifications measuring 3 by 1.5 by 2 centimeters in size, seen at the superior portion of the right lobe. There is also minimal peripheral and central vascularity seen in the color flow, and there are no solid or cystic mass lesions noted in the left lobe. Visualized vascular structures, trachea, esophagus, and strap muscles are unremarkable, and there are no enlarged cervical lymph nodes noted. The visualized parotid and submandibular gland appear symmetrical in size and echogenicity. So to interpret there is a hypoechoic mass with incomplete peripheral calcifications in the right lobe of the thyroid gland. This is category 4, moderately suspicious in the system to categorize it. So there is, yeah.
Okay, thank you, Kyla. Okay. Now, so after we discuss our preclinical paraclinical diagnostic, we can now proceed to the treatment. And before we choose the treatment, we will first decide on the pre-treatment diagnosis, which is obtained from our repeated assessment of our clinical diagnosis and paraclinical diagnosis and their correlation.
Okay, so given the given the clinical and paraclinical findings, so we would like to revise our pre-treatment diagnosis. So for us now, the primary clinical diagnosis would be thyroid carcinoma, since as mentioned earlier, to reiterate lang, so our ultrasound findings were a hypoechoic mass with incomplete peripheral classification. So that puts our patient to Thyroid's category 4, moderately suspicious, and looking at the guidelines, it points to 70 to 90% yung chance na malignant siya. So it's more likely nga na thyroid carcinoma yung mass as opposed to a simple goiter. Now, given this revised pre-treatment diagnosis, so we'll go na to the treatment goals. So but to establish your diagnosis, yun nga, we still have to do the FNAV, but for the sake of discussion, for this one, we're gonna focus mainly on discussing how to manage thyroid carcinoma. So with this, our goals for treatment would be, of course, to remove the primary tumor and possible disease that has extended beyond the thyroid capsule, and if there are clinically significant lymph node metastasis. But in our case, parang wala pa naman tayo na-identify na ganun. Then we'd also want to minimize the risk of disease recurrence and metastatic spread, and which actually plays a role, and surgery would play a role in achieving that objective. Then afterwards, we would want to facilitate post-operative treatment through radioiodine ablation if needed, and also permit accurate staging and risk stratification of the disease. And then afterwards, we'd want to have an accurate long-term surveillance to watch out for disease recurrence, and we'd want to minimize treatment-related morbidity. So with these goals in mind, so let's decide naman na on the treatment modality. So for this, following the format, so we usually decide between non-operative or operative. So if non-operative, usually the option is radioactive iodine therapy. So here, the benefit for this one is it's a non-invasive procedure that allows for the destruction of remnant malignant tissues. Pero I think it's important to note na for thyroid carcinoma, kasi we mainly use radioactive iodine therapy as an adjuvant therapy. And as an adjuvant therapy, it does decrease disease recurrence and disease-related mortality. And if we do use a radioactive iodine therapy, so for follow-up sessions, so it increases the sensitivity of follow-up sessions, and if we use radioactive iodine therapy, so during full body scans, mas effective na siya in detecting local regional and metastatic disease. And this would also maximize the therapeutic effect of subsequent treatments. However, with this management kasi, it would require the thyroid hormone withdrawal for 3 to 4 weeks prior to therapy. So once we do that, the patient becomes at risk for developing hypothyroid symptoms. And during the procedure itself, so there are like early and late side effects that present. So some of the early side effects that presents with radioactive iodine therapy is acute cellulitis, xerostomia, smell abnormalities, epistaxis, styriditis, ageusia, nausea, vomiting, and stomatitis. Then later on, so the cellulitis can be chronic. Then xerostomia can persist also, and there can be like salivary duct obstruction, shrophthalmia, epiphora, conjunctivitis, and possible recurrent laryngeal nerve injury, hypoparathyroidism, pero those are rare complications naman. And like, pwede din siya mag-present with acute radiation pneumonitis and pulmonary fibrosis, pero those are also rare complications naman, pero I think it's important to note lang. And in some cases, they also present with transient decreased ovarian or testicular function, neutropenia, low platelet count, anemia. And years after the therapy, sometimes patients can present with bone marrow aplasia and infertility. And with regards to the cost, so it starts at around 8,000 pesos per session, pero that doesn't account for the doctor fees yet. So it's just for the session itself. And with regards to availability, it's quite limited since most of the institutions that offer it are only found within the National Capital Region. So with that naman, let's compare it with the operative procedure. So with operative procedures naman that it's involved in managing this case can be either total thyroidectomy or lobectomy. So for total thyroidectomy, so it allows for recurrence to be detected more easily through ultrasonography. And if we remove the entire thyroid kasi, we can use the thyroglobulin as a tumor marker. And with this, mas madali nang mag-proceed with radioactive iodine ablation with therapy since halimbawa, if you do a lobectomy, then you find out, oh, you have to remove more pala. So you'll have to have a second operation to enable yung radioactive iodine ablation as an adjuvant therapy. And since with total thyroidectomy, you remove the entire thyroid, so it would minimize disease recurrence compared to more conservative options. However, with lobectomy kasi, since we don't remove the entire thing, so thyroid replacement becomes necessary only for around 10% of the cases. And with regards to the risk, so actually, well, with this, since it's an invasive procedure, so pero this one has like low infection rate, and for most of the cases naman ng total thyroidectomy, it doesn't even need antibiotic prophylaxis. But then, if we do proceed with this procedure, so it would necessitate thyroid hormone supplementation for a lot of cases, for example, total thyroidectomy. And possible complications during the surgery itself include wound seruma, hematoma, and hypocalcemia, secondary to hypoparathyroidism, and possible nerve injury. Pero looking at the complication rates naman across several studies, they're generally low naman. However, with the cost, it costs like 25 to 75,000 pesos. And with regards to availability, so it's available in PGH, but it's still mainly offered in private institutions. And availability will mostly depend naman talaga sa patient's financial capacity and the hospital na they choose to have the procedure done. So given these, so I guess we can discuss naman now what we decided. So should we proceed with an operative or a non-operative procedure for this one?
Okay, so based on access discussion of the operative and non-operative options, we decided that the treatment modality we can suggest for our patient is the surgical management. So according to studies and also the CPG for thyroid cancer, it is suggested and recommended that any tumor greater than 1 centimeter and less than 4 centimeters without extrathyroidal invasion with no clinical data of lymph node metastasis can be managed surgically, either by a bilateral, total or near total thyroidectomy or a unilateral surgery, which is the lobectomy. So the lobectomy, just to round that down, it may be sufficient if you have lower risk papillary and follicular carcinoma. Additionally, the other option, the total thyroidectomy, it's also suggested, especially if you have consequent radioiodine therapy, the one that accessed a while ago na pwedeng adjuvant. The studies also found that total thyroidectomy enables a reliable follow-up since thyroglobulin, which is used as a tumor marker, is expected to be undetectable if the thyroid is removed. Moreover, in a more local setting, the same management options are also recommended, since I also found parang the hospital's own CPG for thyroid carcinoma, and it said that they made the consensus to maintain the original recommendation of total or near total thyroidectomy for all patients with well-differentiated thyroid cancer and a nodule size greater than 1 centimeter in its largest diameter. In these guidelines, a thyroid lobectomy may be sufficient treatment for thyroid cancers 1 centimeters or less in diameter, isolated intrathyroidal, and without cervical lymph node metastasis on preoperative ultrasound. But to reiterate, our patient has a mass that's already 4 centimeters by 4 centimeters. So that's why we chose to opt for the surgical management and most likely a total thyroidectomy. Okay, so moving on to the next part. So if we're gonna do this surgical management, of course, we have to evaluate how effective it is on our patient. So after a total thyroidectomy, post-operative thyroid hormone therapy, T4 or levothyroxine, is necessary to replace normal hormone production and suppress tumor regrowth. The details on dosages and other technicalities of this therapy will depend on the estimated risk of persistent or recurrent disease. Immediately after the operation, complete clinical pathologic findings may not really be fully available yet to estimate these risks, which means it's necessary for the clinician to modify the dosing of this hormone therapy 4 to 6 weeks post-operatively. So furthermore, to monitor the patient's response post-op, we will be monitoring thyroglobulin and thyroglobulin antibody levels every 3 to 6 months after surgery. The outcome of our proposed treatment, which is the surgical management, which will be evaluated by monitoring the patient's response to this procedure, and the response to treatment can be evaluated based on the modified ATA dynamic or ongoing risk stratification system, which classifies the response as either excellent, biochemical incomplete, structural incomplete, or indeterminate response. So this is the system used by the CPG for thyroid carcinomas, and there's a more detailed explanation of the parameters to classify the patient in each category. But in the next slide, that's the gist of the response. So for excellent, there's no clinical, biochemical, or structural evidence of disease. For biochemical incomplete response, there's an abnormal thyroglobulin or rising antibody levels in the absence of a localizable disease. For structural incomplete, there's persistent or newly identified locoregional or distant metastasis. And for indeterminate response, non-specific biochemical or structural findings that cannot be classified as either benign or malignant. So these will all come after the operation and in the monitoring stage of the patient. So before we move to the next, in the paper, doc, it was asked na if there's data available, present the treatment procedures done on the patient and their outcomes. So since it's a paper case and there's no treatment yet done, there's no data on procedures done on the patient and its outcome. So
Okay, thank you, Gaty. So now that we've finished discussing about the treatment, let's proceed to the prevention and health promotion.
Okay, so next slide, please. So there are certain risk factors that may predispose someone to thyroid cancer. The first and major risk factor, and also the most well documented, is exposure to ionizing radiation in childhood. So certain procedures may expose children to large amounts of radiation. So for example, children who were treated with radiotherapy for childhood cancers of the head and neck, so example, Hodgkin's lymphoma. And then also in America, apparently there were children who had acne who were also treated with radiation. So these risk factor would make them more susceptible to thyroid cancer. Next, second are the patients with a family history of thyroid cancer, especially first-degree relatives. So thyroid cancer, such as medullary carcinoma, may present within a syndrome such as Men's syndrome, or the patient may also have familial adenomatous polyposis. So these conditions may be inherited. So patients with these risk factors should regularly visit their doctor and make sure to have their annual physical exam. So this will be further discussed in the next slide. But other than those stated, according to the American Thyroid Association, there are no direct explanations for majority of cases of thyroid cancer. So next slide, please.
So what advice would we now give to patients? Asymptomatic or apparently healthy adults do not need to undergo rigorous screening for thyroid cancer other than the usual annual checkup. And in the clinics, physicians will screen for thyroid cancer by palpating the neck, and if available, an ultrasound may also be requested along with it. Patients should be cautious and notify their doctor if they feel or notice a lump in their neck that has grown within time. It can be explained to the patient that a lump in the neck region can be a variety of different conditions ranging from benign to cancerous. Thus, it is best to talk to a doctor about this. With thyroid cancer, only a small number of patients will present at advanced stages. However, we still advise for them to go for screening if the patient is at risk. Thyroid cancer at an advanced stage would present as cough, difficulty of breathing and or swallowing, or hoarseness of the voice as the tumor has grown large enough to push on the adjacent structures in the neck, such as the esophagus, trachea, or the windpipe, and the laryngeal nerve, which is responsible for our speech. Next slide, please. So branching off from treatment and prevention, we can now proceed with journal appraisal. So for our journal appraisal, we wanted to ask the question, among adults with thyroid cancer, does total thyroidectomy treatment improve survival, overall survival, and recurrence-free survival? After a PubMed search, we chose the article titled Total Thyroidectomy versus Lobectomy for Papillary Thyroid Cancer, a systematic review and meta-analysis. So this article focuses on the surgical treatment approaches and its effect on the survival of thyroid patients post-surgical treatment. And it also did a subgroup analysis on the effect of these two treatments depending on the size of the tumor. So to first appraise the directness of the article, we compare the PECO of our clinical scenario and the PECO of the journal article. So in terms of population, our patient is a 54-year-old female Filipino diagnosed with thyroid cancer, while the journal article's population consisted of patients diagnosed with papillary thyroid cancer. It is also important to note that the patients in this article originated from two countries, namely the United States and Korea, and this information would help us determine the journal's applicability later on. As for the exposure and outcome, we wanted to determine overall survival and recurrence-free survival of those patients who underwent total thyroidectomy, while the article compared these outcomes in two groups of patients, mainly those who underwent total thyroidectomy versus those who had lobectomy. Next slide, please.
Okay, so there are certain questions that we can answer in order to appraise validity of the study. So the first would be, were the criteria for inclusion of studies appropriate? So our answer to this is yes, because inclusion criteria was consistent with clinical question and the exclusion criteria was also found to be appropriate. However, the authors failed to explicitly specify what types of studies they were willing to include, such as case controls, cohorts, and etc. However, the score that they used, the NOS score that they used for appraising the quality of included studies, can be used for cohorts, case controls, and cross-sectional studies, and it can be assumed that it was a cohort study based on a table that was in the journal. However, they did not explicitly mention this, and so they didn't specify either if the studies, the cohort studies, were prospective or retrospective cohorts that were used. So other meta-analysis would actually explicitly mention this for the sake of clarity. So that's something that's lacking in this journal. Next, was the search for eligible studies thorough? The answer is no. It was incomplete because they did not consider unpublished literature or literature written in a foreign language. However, they did use a funnel plot in order to assess for publishing bias, and their findings was that there was no apparent evidence of publication bias. However, based on the methodology, we could still say that no, it was not complete because they did not use any other source other than a database for their search for studies. Next was the validity of the included studies assessed. Yes, but it's also incomplete. The quality of the included studies were evaluated using the Newcastle-Ottawa scale, or the NOS scale. NOS. So again, the assessment was seemingly incomplete because it lacked significant information that are usually disclosed in the meta-analysis, such as the inclusion and exclusion criteria of each study and the possible biases. Furthermore, the authors did not explicitly state information regarding the randomization or allocation concealment in the methodologies of the studies used. However, we can infer from the use of the NOS that non-randomized studies were used because it's a scoring system for non-randomized studies. They also did put the NOS score in a separate table, but not under the table of characteristics. So it's a little medyo kalat-kalat po yung information, so it could be better organized. And all the studies were rated a 8 to 9, wherein they didn't include any studies that were rated anything less than 6. So lastly, were the assessments of the studies reproducible? Yes. There were at least 2 authors who evaluated the quality of the included studies, and disagreements were resolved through discussion, which is an acceptable practice. So that's all for validity.
Right. So after questioning validity, we go on to question the results of the study. So let's first talk about the results regarding the outcome of overall survival. So the combined estimate or the full estimate for the question of whether thyroidectomy versus lobectomy, which is better, is that results show that neither is better than the other. As we can see, it's very hard to see in this figure. So we see that the pooled estimate, the interval estimate crosses the line that says that neither is superior or inferior to the other. So for the outcome of overall survival, we can say that according to this combined estimate, that thyroidectomy and lobectomy have no significant difference when it comes to overall survival. But if we look closer at the heterogeneity of this pooled estimate, it's quite heterogeneous at I squared equals to 72%. So it would actually benefit us to do a subgroup analysis, as mentioned earlier, to determine better which is beneficial. And we do the subgroup analysis according to tumor sizes, excluding metastatic diseases. So first, for tumors less than or equal to 1 centimeter in size, the result is also the same. There's no apparent significant difference between thyroidectomy and lobectomy. And the same is true for tumors of sizes 1 to 2 centimeters. But the difference becomes apparent and significant when we consider tumors of sizes 2 to 4 centimeter, in which case thyroidectomy appears superior than lobectomy in terms of overall survival. Next. So the other outcome that we're considering is recurrence-free survival. Again, we look at the combined pool estimate for the studies, and this shows that in terms of recurrence, total thyroidectomy is associated with significantly less recurrence than lobectomy, and this makes sense in practice. Again, this is quite heterogeneous, so we do a subgroup analysis according to tumor sizes. So when we consider tumors less than or equal to 1 centimeter in size, we again see that total thyroidectomy is superior to lobectomy when considering recurrence. The same is also true for tumors greater than 1 cm in size. However, we can consider some of these studies actually show that there is recurrence in the contralateral lobe for patients that received lobectomy. So if we exclude those studies that consider contralateral recurrence, surprisingly, we see that thyroidectomy and lobectomy have no significant difference when considering recurrence. But the applicability of this results is unclear because of imprecision. As we can see, it's such a wide interval estimate. But in practice, we can consider the first three pooled estimates that show that thyroidectomy is indeed better than lobectomy when we consider recurrence. Next. So after questioning the results, we now go on to appraise the applicability of this study. So we have six categories for us to peruse the applicability of this study. So namely sex, comorbidity, race, age, pathology, and socioeconomic status. So for sex, prognosis tends to be worse for males than for females, despite papillary thyroid carcinoma being more common in females, as emphasized earlier. So that study in question dealt with females and males, but our specific clinical scenario deals with a female patient. So it's possible that whatever surgical approach that this patient will undergo, the prognosis may still be good because prognosis tends to be worse for males. Next is comorbidity. And cancer patients tend to have comorbidities that may contribute to the probability of all-cause mortality. The study did not mention of any comorbidity being considered in the analysis, and thus we're not sure if the survival is primarily due to the surgical treatment that these patients received. Next is race. Papillary thyroid carcinoma in Filipinos may hypothetically behave slightly differently or may exhibit a variation in the natural progression of the disease compared to the disease in Americans or East Asians. Recall that the study dealt with patients from USA and Korea. Next is for age. So the age of the patient is a very important prognostic marker. As stated in Harrison's, patients age more than 65 years tend to have poor prognosis and are staged more with advanced disease. In consensus, patients age less than 55 years are staged until only stage 2. Despite any tumor extent or nodal involvement, they are only staged until stage 2 because it was observed that these patients in this specific age group tend to have better prognosis than patients in the upper age group of more than 55 years. So moving on to pathology, the pathology of differentiated thyroid carcinomas, whether papillary or follicular, is essentially the same across patients. So it is unlikely that the pathology of the disease may affect the applicability. And lastly, we consider socioeconomic status. And for here, the thing is that the access to affordability of the definitive treatment, that being surgical approach, can affect the survival. So this was mentioned earlier, and this boils down to whether or not the patient can indeed afford a surgical treatment, or may just rather go with a palliative or non-surgical treatment. Next. So we go on to individualize the result of this study to our specific patients, and what are the things that we should consider before doing so. So as mentioned, in the local clinical practice guidelines recommend total thyroidectomy for tumors greater than 1 centimeter in size. However, we must remember that there is no compelling evidence that total thyroidectomy is better than lobectomy in terms of survival when considering tumors of 1 to 4 centimeters. This was also supported by the study that we were appraising. However, the caveat for lobectomy is that it is without a doubt associated with more recurrence. So with that said, the decision to undergo total thyroidectomy or lobectomy must be individualized based on patient preferences, expectations, and risk factors. This is a paper case, so we were not able to assess the patient ourselves, but if it so happens that the patient was at high risk for recurrence, may be possible that the family history of goiter is actually a huge risk factor for recurrence, then indeed we might have to go with total thyroidectomy for this patient. Otherwise, either thyroidectomy or lobectomy would suffice for this patient. So that ends the journal appraisal.
So this ends our case presentation, and here are our references po.
Okay, thank you. Okay, how do we process this? Okay. Number 1, paper case. This is a paper case. Okay. But you're now in the OPD, right?
Hindi pa po kami, Doc, nag-OOPD pa po. Ongoing lectures pa po, Doc.
Ongoing. Okay.
Yes, yes, Doc. This is part po of our oncology module po under OS 217.
Oncology module.
Yes po.
Who is the coordinator of oncology mo?
Si Ma'am Kanyal po.
Radio.
Yes po.
Radio. Okay. Sige. Iba pala ito. So, paper case. So, we just have to accept it. So walang needle biopsy, walang data on treatment. right? Wala. Okay. So what you had is just the history and physical exam data,
Yes po, tsaka yung ultrasound po, Doc.
yung ultrasound. Okay. Okay. So that's one clarification. Second, okay. I will ask some questions, no? Yung ano lang muna. Okay. Okay. Somebody mentioned the one who presented is, did I hear you right? Thyroid cancer is the most common cancer in females. Sino nag-present?
Yes po.
Si Maria Angelica. Okay. Thyroid cancer is the most common cancer. Hindi ba breast? Hindi ba breast?
Sorry, more common in females. Sorry. More common in females compared to men. Sa incidence po sa Philippines, sorry.
More common
17.3 compared to 7.3 per 100,000 males.
in comparison with whom? With the males?
Males po, males.
Males.
Yes.
Okay. So anyway, so at the moment, breast cancer is still the most common among females, or practically all over the world. Okay. Okay. In the Philippines, ganun din. Okay. Yeah, the thing is, okay, the other question is the one who presented options in the treatment. Operation is usually offered in the private hospital. Sino nag-present na? Just want to have a clarification. The one who presented comparison of RAI and surgery. Sino?
Doc, for that parang we noted lang na parang it's more available lang yung operation sa like private. It's mostly offered in private institutions, but I think that's
Pero-
what we.
Pero Axel said din po na meron din po sa PGH.
Yeah. Thyroidectomy is a common, I'm not going to say it's simple, but it's an operation that's being done practically everywhere. Okay. So even in missions, when we go for surgical missions, now we usually have a lot of thyroidectomy. Okay. So it's not only in private, but in government hospitals. Okay. Okay. So I might have some more questions, but the next thing that I want to, we have to decide on something. You want to ask questions first before we go to the discussion of the case using the patient management process. I'd like to congratulate you for at least attempting to use the process. Okay. So this is the first time to be exposed to that. Okay na yun, but you can feel the process, but it's a matter of trying to refine what the content in the process. Okay, which I'm going to discuss later on. Okay. So you want to ask questions first? Any questions that you might want to ask me?
Doc, for this case po ba, since wala kaming naging FNAB, parang is it still sound po ba na, for example, given lang yung ultrasound findings, na we still proceed with, like for example, surgery, or we do need po talaga na mag-FNAB muna before we proceed with possible surgical interventions for this case?
Okay, good questions. The starting point of what do you call that? Okay. The starting point is always the diagnosis. Okay. So medicine is actually essentially problem-solving decision-making. And okay. And then when you try to solve the problem, you start with the diagnosis. You start with the clinical diagnosis, then later on, you can input some of the laboratory diagnosis that will come in. Example of laboratory diagnosis will be your needle biopsy, will be your ultrasound. Okay. So a lot of times, what's most important is that you start with the clinical diagnosis. So clinical diagnosis is based on symptoms and signs. So symptoms gotten from the interview, from the history, and then signs will be those gotten from the physical examination of the physician. So when you come out with, you have to formulate a clinical diagnosis, at least two. Okay, there's no such thing as 100% certainty in medicine. So dapat at least two. Okay, so yung primary will be the most probable, and then secondary would be the second most probable. Okay, so if your diagnosis is something that you are most likely sure of, you don't have to go to a paraclinical like the needle biopsy. Okay. Or in your case, you're saying that you have ultrasound already. Diba? Ultrasound is part of the paraclinical. So in ultrasound plus your clinical diagnosis, you put them together, okay, integrate it, and then come out with a diagnosis. So if your diagnosis is that you are strongly suspecting cancer, okay, so you go back to the basic questions. How certain are you that it's cancer? If you're quite certain, you don't have to do the needle biopsy. Okay, so you can go direct to the treatment already. Get it? Na? Yung importante itong process na tinuturo ko sa inyo eh. Na? Okay. Okay, there's some guides, some rules to, it's not absolute, but at least there's some guide. No? It's a process. No? Okay. Okay. Okay, Alexis?
Yes po. So
Okay.
since yun nga po sa CPGs, it was mentioned kasi 70 to 90% na siya since it was established sa ultrasound na may microcalcifications na siya. So parang, does that mean na the therapeutic thresholds na we don't test na further? Diretso na tayo surgery po, ganun?
You're saying that the based on that so-called guidelines, based on ultrasound findings, you're already certain that it's cancer?
The guidelines mentioned po na based on the studies they pulled po, once pag given yung findings po na hypoechoic mass with at least one of the following, tas kabilang po dun yung microcalcifications, the risk of malignancy is greater than 70 to 90% na po agad.
Okay. So, but caution lang, you have to know how to interpret, no? As a clinician, no? There are a lot of variations, lack of unreliability, no? Subjectivity in the ultrasound report. So these reports will have to be correlated with your clinical findings, with your PE findings, no? Okay, example, okay. Ultrasound, before the advent of thyroids, okay, ultrasound, there are a lot of thyroids. You're talking about ultrasound, right? Thyroid stands for thyroid imaging, reporting, ano yan? Reporting and anong A? System. Something system, di ba? Just like in BIRADS in breast, you have breast imaging, reporting, and I forgot what.
Data system.
And
Data system.
data system. Wala na yung A, no? Okay. So, maraming mga T4. So, ito T4. In your patient, nakalagay doon T4. Di ba? Ano yung classification ng T4? Moderate or mild? I mean,
Moderate.
Moderate. Okay. So the mere fact that they use the term moderate, suspicious, no? Sometimes they use suggestive. Okay. Are you aware of those terminologies that they use? Okay. So sometimes they use suspicious, sometimes they use suggestive. Okay. So which one has a greater weight? Ganun din sa pathologists. When they give out report, especially in needle biopsy, they will say suggestive, na suspicious. Okay. So as a clinician, you must know how they use these terms, and so that you can input it to your clinical decision making. Na, so ang mas mabigat dyan is really suggestive. Na, pag sinabi, T4 is suggestive, wala, no? Moderate, no? Moderate. Okay. Moderate ang ginamit nila, di ba? Moderately suspicious. So they can have another variation is minimal suspicious. No? Tingnan natin yung BI-RADS. Ano yung sa BI-RADS? Are you aware of the BI-RADS sa breast? Ano yung T4? Can you check? T4? What term do they use?
High suspicious for
Suspicious of
malignancy.
malignancy.
Suspicious.
4A,
Malignancy.
Low suspicion.
low. Okay. 4B,
Moderate
Moderate.
suspicion.
moderate. Di ba? Okay. May 4C pa ba?
High suspicion.
Okay. And then 5,
Highly
Highly
suggestive.
suggestive. Nakita niyo, they use the word suggestive now. Okay? So, maraming variations. So, ang implication nun, there are a lot of subjectivity also. Di ba? As I may mild, moderate, and then there's such thing as suspicious, suggestive. No? Okay. So just take note of that. Now, there are a lot of variations like of subjectivity, kasi variations in terms of who is reading it. Di ba? Okay. So for one pathologist or one ultrasonographer reading it, baka sa kanya 4A or 4, sa iba 3, iba-iba. No? Okay. So in the end, it will be the clinician who should make the decision. If he is a clinician who relies on the pathologist on the report, yeah, tuloy-tuloy na yon. No? You will just base the report. Pwede siya magkamali. No? Okay. So the best will be a clinician who can correlate everything, who knows the ins and outs of the reports. No? Okay. So he must know how to interpret. No? So in this particular case, ThyRADS 4 sa thyroid. Anong basis niya for 4? Walang sinabi.
Hypoechoic po siya. Tapos may classification. So 2 points each na po yun. So total point of 4, pasok na po siya sa THRADS 4.
ThyRADS 4. How about the size?
7 points and above po. So for 4, it would be 4 to 6, and then 7 would be and above would be THRADS 5 na po.
Okay. So may size pa, di ba? Meron pang tall versus wide, over wide. Ganon, di ba? Okay.
Yes,
So a lot of subjectivity there. No? So when you say hypoechoic, it's solid. No? So wala siyang binanggit na cystic area. Okay? So it's purely solid. No? And then microcalcification. So they can put some points there, and then they will also use the taller than wide or wider or taller. Ganun. May point system yan eh. No? So makikita mo yung mga point system, it contributes to the subjectivity of the reporting also. No? So hindi siya absolute. No? So you go back to other backup what do you call that? Other things that can back up your decision. Okay. Example, on the clinical diagnosis part, no, you palpated one solitary nodule. Diba? Isa lang sa left lobe, wala sa right lobe. No? So that you have higher incidence of thyroid cancer if you have solitary nodule compared to multiple nodules. Okay? So if a factor in mo rin yun, no? Okay. And then your PE shows that it mentioned doughy. but I don't usually use the word doughy, whether it's hard or not hard. No? Okay. Whether it's firm, soft, or hard. Probably when it says doughy, baka it's implying that it's soft. No? Okay. Soft. Pag soft, pag hard siya, most likely cancer. Pero kung soft, pwede pa rin. No? Okay. Because a thyroid, papillary thyroid cancer can also be a little soft, but follicular cancer usually softer than papillary. No? Okay. So yung nature, yung consistency of the mass can also give a clue as to whether you are dealing with a cancer or not. And then the other one is whether when you press on the thyroid nodule, whether it's cystic or not. If it's cystic, malamang benign siya, no? Okay. So in your PE, walang that's one thing that is lacking. No? They should put there whether it's solid or cystic. Kung wala kang data noon, you just base it on the ultrasound. The ultrasound did not mention cystic component, just a hypoechoic mass. Most likely it's a solid. No? Okay. So ganon. So based on your PE plus your ultrasound, you might agree that most likely you're dealing with a thyroid cancer because it's solitary, okay, kahit na walang lymph nodes, okay, and then it's solid, okay, solid. Yun lang, no? Wala nang iba, no? Yung calcification, it's not very, very strong, no? Okay. So you can, that's why you have a good reason for changing your primary diagnosis to thyroid CA. This is after you get the ultrasound report. Now, so initially your diagnosis, you mentioned that the simple goiter, no? Okay. But you must have a basis for that, no? Okay. So ano yung magiging basis mo for simple goiter?
For the simple goiter, Doc, we chose na it was since it's gradually enlarging. Tapos the patient has a family history of goiter, and it's common daw po among females, especially those above 40 years old din po.
Okay. Right away, my input here is do not, kasi tayo focus, we put priority on something, na? Okay. Yung iba, nice to know. Nice to know lang yan, na? But these are not proven. Yung family history, na, is not a sure shot for a simple goiter, na? Okay. So you can have a family history of cancer, di ba? Tama? O family history of goiter, parang pareho lang no? Okay. Well, what's more important is your physical examination, no? Your physical examination part, no? So when you say doughy, I assume it's soft. Okay. Tama? Let's use kasi I don't use the word doughy. Kasi doughy parang donut na pinipindot mo na babalik siya, no? Para most likely soft lang yon, no? So if it's soft, no signs of malignancy, no? Okay. And based on prevalence, is the most common, no? Okay. So a soft tumor, solitary tumor, no, on the left lobe with no neck nodes, no, you have a choice between goiter, tama kayo, goiter and CA, no? Okay. But if you base it on prevalence, kasi you use pattern recognition for these two, no? Okay. Then you have to decide which one should be number one, which one should be number two. Okay. So where do you put more weight? The prevalence, okay, or yung one-sided? You have to decide, diba? So as we know that goiter, probably 90% of thyroid disorders of goiters are 90% are goiter. That's why you choose simple goiter as your number one. Tama ka, no? Pwede, you have a basis for choosing that, no? But you have to factor in yung solitary, no? Okay. So yung how you have to know the data. If you have data, let's say kung 90% of solitary nodule, no? okay, or cancer, then you would put cancer as your number one. Okay? But if you don't have neat data, baka ano lang, probably 10%, 20% lang, no? Then you still put in your goiter as number one because yan ang pinaka-common eh, no? Okay? So, nakikita niyo it's an educated guess, no? Basta may basis ka, no? Okay? Okay. Initially, hindi mga hard data ang kinukuha mo kasi hindi natin alam yung talagang mga statistics, di ba? Okay? But at least you have a feel, you have a parang may inkling ka that this is ano, okay? And then use it as a reason. Okay? Kung nagkamali ka, when you discover that you were wrong in your diagnosis, you learn from it. So next time you will change yung mga processes, na yung mga statistics mo, na. So you learn along the way, na. Okay? Okay? So you have to Alexis, to end this short discussion on the question that you posed, no, you have to correlate it with the clinical findings, na. Okay. Ibabangga mo, na. Okay. 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 Any more questions? Wala? Before we discuss the case? Anyway, paper case ito, di ba? Okay. So we start you're now LU5. LU5 is third year, no? What? Third year, no? So you have studied a lot of things about thyroid from your anatomy, from your physiology, biochem, ano pa? Pathology. Ano pang dinaanan niyo that touch on thyroid? Endocrinology, meron na kayo? Endo? Okay, marami, di ba? So this is about time to use all this information and integrate that and see which will be useful in the patient management. Okay. In the end, what counts is really the patient management process, di ba? Okay. So you must know this process. No, you can input some of the background knowledge that you have and then put it into the patient management process. Dinidiscuss natin pathophysiology, di ba? Ganon, no? Or you can use the process first with some inkling, with some background knowledge on the theoretical data. Na pag nakakuha ka ng isang diagnosis, then balik ka dun sa pathophysiology to see whether it jive. Na ganon, na okay. Parang reiterative, na okay. So integrate na lang natin, ha? So let's focus on the patient management. Na. So you have a how old is the patient?
54 po.
Female. So this patient presents with an anterior neck mass. Okay. When you say anterior neck mass, you still don't know what is that mass. Where is that mass originating, diba? And actually, the phrase that is being used is the term that is used by the physician in recording. Usually, hindi may pasyente magsasabi sa iyo, I have an anterior neck mass, diba? Tama. Nasabi ng pasyente, minsan alam nila, Doc, may goiter ako. You ask the patient, anong concern ninyo? Bakit kayo magpapatingin? Ito, tuturo nila. Or, kung alam nila, because somebody told them that may goiter, Doc, may goiter ako. No? Sabi na, may bukol ako rito. Ganun. Okay? So, it's a doctor who will place on the history, on the medical recording that the concern is anterior neck mass. Okay? Okay. So anterior neck mass it's not automatically, it's not thyroid. Diba? So what you just described, that there is a mass that you saw or the patient is pointing to a mass in the anterior side of the neck. No? Okay. So anterior neck mass, the anterior neck mass can be anything anterior to the neck, which could be in the paramedian, central, or lateral. Tama? Okay. Or kung tinuro ng pasyente, Doc, may bukol ako rito. Anong ilalagay mo noon? Lateral neck mass. Di ba? As a physician. No? Okay. So if you want to split here, you can say anterior neck mass will refer to the one in the paramedian, paratracheal area. Those on the side, lateral neck mass. Okay? So assuming that it's on the, let's say, in the midline, no? So right away, iniisip mo na, paper case kasi ito, di ba? Kasi hindi niyo nakikita, no? Binigay na sa inyo, anterior neck mass, no? And we know that ito yung pinaka most commonly used term by physicians to refer to the goiter, di ba? But you have to validate that. Tama? Okay. So the first thing that you do, the patient management process as a tip lang, no? When you're dealing with patients, you don't have to spend so much time in interviewing the patient, getting the family history, no? Yung mga social history, ganon, no? Okay? So you go straight right away. Kung minsan sabihin mo, how old are you? So yung sex, alam ninyo, di ba? What's your concern? No? Sabihin niya, ganito, no? And then, you just probably can ask one question. Pag sinabi niya dito, you can start doing your physical exam already. No? Okay. So you don't have to go to the mga family history muna. No? Okay. Diretso na ninyo, kapain na ninyo. No? Okay. So kung kinapaan niyo yung leeg, no? Okay. At you have your findings already, that will give you a clue what you're dealing with. Di ba? Okay. So yung pasyente nito, sinabi niya, anterior neck mass, kapain mo. Kagad. No? So in 1 second, kasi the whole process will take you about, kung minsan 10 minutes lang, matatapos mo na lahat eh. No? Okay. Kung expert ka. No? Okay. Matagal, kung nahirapan ka, 15 minutes. No? So, but don't spend 30 minutes on a patient. Matagal masyado na yon, di ba? Okay. So, kapain na ninyo. Then, while you are making kapa, doing your PE, you can ask more questions along the way. No? Habang kinakapa mo. So, you can ask, kailan pa niyo napansin ito? No? So, don't use the word, kailan nagsimula ito? Okay. It's hard to answer that question, di ba? So, kailan niyo napansin? That's the better question to ask. Okay. Even tayo, when we have a condition in the body, we can never tell when it started, di ba? Mahirap i-recall, di ba? So, when it was first noted na lang. Okay. So, in this particular patient, 6 months, na? Okay. So you can ask another question, gaano kalaki ito compared to this one 6 months ago? No? Okay. Okay. Rather than putting just progressive increase in the size of the mass, you try to assess, baka yung 6 months ago, ganun lang 1 centimeter, 2 centimeters lang nakapa niya. Ngayon, 6 months, naging 4 centimeters, you can already assess the rapid growth, no? The rate of growth. Kung nakapa niya, probably at 3 centimeters 6 months ago, and ngayon 4 centimeters, you can say, negligible yung growth nito. Na? Okay? Okay. So when there's a mass, you try to see, to check ano ba yung, try your best lang. Kung kadalasan, baka sabihin, kadalasan masasabi nila, but just an estimate, yung mga pasyente. No? Just ask them to compare it to the size of a seed or a coin, whatever. No? Ganon. No? Okay. So wala tayong data doon. No? Nakalagay doon sa case ninyo, just there is progressive increase in the size of the mass. Yun lang, di ba? Okay. So progressive increase. Okay. So we have some data already. And then you go back to the PE. So the PE shows that it moves with deglutition. Okay. So the moment there's a mass there in the anterior side of the neck that moves with deglutition, it's thyroid in origin until proven otherwise. So 99% sure ka it's thyroid, not 100%. As I said, nothing's 100%. No? So ano yung 1% that can move with deglutition? Ano yung 1%? Give an example. Ayla? Stretch out your imagination.
Sorry, Doc, could you repeat po the question?
Kaya nga eh. Sige, tinetesting ko lang kayo kung nakikinig kayo sa akin. So sabi ko, if you have anterior neck mass with moves with deglutition, 99% thyroid in origin. And I said that there's no such thing as 100% in medicine. Now, what could be an example that will exemplify yung 1% that ano? Anong part of the neck area that ano? That can also move with deglutition but not thyroid.
Doc, may I guess?
Ah.
Like something like a dermoid cyst po, like sa skin po siya sa front. So hindi siya thyroid pero baka it moves along with like the skin kasi.
Moves with the skin, pero it does not move with deglutition, with swallowing. Tama? So you have to look for yeah.
Cricoid
Rene.
thyroid, yung cricoid ano.
Meron po tinatawag na thyroglossal cyst.
Thyroglossal cyst. Sige, pwede rin. Pero yung aside, related to the thyroid yun eh. Something that is not thyroid in origin. Anong in that area that anong organ?
Pwede po ba yung Adam's apple or laryngeal prominence? Although female po kasi yung patient eh. Kaya baka hindi rin.
Very simple lang naman ito. Ano yung mga anatomy? Sino nag-discuss ng pathophysiology anatomy pattern? Sino? Ikaw ba? Siyan?
Yes po. Yes po.
Ano yung anatomy of the neck? That's yung malapit sa thyroid. That moves with swallowing also. Tingnan mo yung leg mo. Okay. So you have what? Sa center. Yung thyroid.
Trachea.
Oh, yeah, trachea.
Trachea.
Okay. So a tracheal mass can also
okay.
be a mass in the anterior area that moves with deglutition. Tama? Okay. Binibigyan lang kita ng example na I'm just trying to drive home the point. There's no such thing as 100%. 99% no? Thyroid. Yung 1%, it could be something else. No? Okay. So a mass in that area, if it's not a thyroid, baka trachea or a thymus. Thymus na nakadikit doon. Di ba? Mga thymoma. No? Okay. Or kumisan, baka yung esophagus na malaki na. No? Umabot na sa gitna, sa labas. Di ba? Okay? The neck part of the esophagus, nasa likod lang ng trachea yun, di ba? Baka nakadikit siya, kaya gumagalaw, no? Okay? But as I said, 99% of anterior neck mass or paratracheal mass which moves with deglutition is thyroid in origin. Na? Okay? So, in your paper case, sinabi niya, anong nakalagay doon? It moves with swallowing? Anong nakalagay?
Moves with deglutition.
Moves with deglutition. Sige. I don't have the copy. But you supply me with the data. Ha? Okay. With moves with deglutition, moves with swallowing. So you're thinking of thyroid already. 99%. Okay. So the next thing to do when you do your PE, okay. Whether you determine whether there is enlargement or nodular formation. Okay. So sinabi ng paper case, may anterior neck mass with moves with deglutition. So thyroid in origin yon, no? So Okay. Pasok natin yung size. May size yan, di ba? Anong size?
3
Anong
by
size?
1.5 by 2.
3 by 1. Okay. Sa
3 by 1.5 by 2.
sa PE ito sa history ito hindi sa ultrasound ito Okay.
4 by
Sa
4
P.
sa P.
Sa P,
Hindi, sa
yes.
PE lang, PE tayo, PE muna tayo. Okay. Sa PE, so
Opo,
3.
Doc.
4 by
Okay.
4 by 4 centimeters.
Okay. So let's just input that size to facilitate our discussion. Okay. And then the first thing that you determine as a clinician, so you're dealing with a thyroid, you're dealing with a goiter. Goiter is defined as any disorder of the thyroid gland. That's the loose definition. Okay, ngayon. Okay. When you say goiter, pag tinanong ka ng mga lay people, ano yung goiter? No? Okay. So you can say that any disorder of the thyroid gland, it can be cancer, it can be anything. No? Although history-wise, sa medical context, when you say goiter, it implies something benign. Di ba? Okay, kaya kanina you use simple goiter, which I will question you later on. No? Simple, yung terminology na ginamit ninyo, simple goiter. Di ba? Okay. Okay, so it's goiter. So the next thing that you have to determine as a clinician, when you palpate the neck, you try to determine, is there enlargement or is there nodule formation? Okay, yan ang unang titingnan mo, no? So if it's diffusely enlarged, no? Okay, then you most likely are thinking of hyperthyroid or hypothyroid. Okay, but if you're talking about nodules, no, you're considering whether it's cancer or not cancer. Nakuha na? Kapainin nyo kagad, determine whether it's enlargement or nodule, may mga nodules. Okay? Pag enlargement, at the back of your mind, hyperthyroid kaya ito. Okay? Or hypothyroid. No? Okay? Okay. Remember, you're just on the 3rd second or 4th 1 minute of your palpation pa lang, di ba? Pero may iniisip ka na. No? Okay. And then if it nodule, nakapanin nyo, most likely, you have to decide whether is it cancer or not cancer. Okay. Okay. Enlargement. Kung enlarge siya, theoretical discussion nito, kung enlarge siya, okay. By the way, itong tip nito, ito hindi masyadong tinuturo sa mga consultants natin, no? So when you say you have heard about diffuse goiter and nodular goiter, no? What is a diffuse goiter? Rene, sige.
Pag upon palpation, the enlargement seems to be that of the whole thyroid gland.
The whole. Okay.
As opposed to nodular, wherein maybe as a whole the thyroid is normal in size, but there's distinct
Okay, nodules talagang makakapa mo, no? Okay. May konting hits dito sa diffuse. A lot of times physicians confuse yung mga diffuse goiter from smooth na enlargement, na kasi nodule may smooth enlargement, akala nila diffuse. Okay. So ang definition ng diffuse goiter is that there are two major lobes of the thyroid gland, right and left. Okay. If the two lobes are almost symmetrically enlarged without nodules, no, then you call that diffuse goiter. Okay. Almost symmetrical kasi hindi siya perfectly symmetrical. Okay, basta almost the same size. Pero kung yung isang lobe is 4 times bigger than the other side, no? Kahit na smooth siya, walang mga nodulation, no? You don't call that diffuse goiter. Okay? You call that nodular already. Kahit na wala kang nakakapang yung frank na bukol-bukol. Okay? Smooth kasi yung ano niya eh. Okay? So, in our experience, when we operated on these patients, they will turn out to be nodular. Kasi yung bukol nasa loob ng thyroid gland. Kaya smooth sa labas. Okay? So yan ang isang ano diyan, isang parang common pitfall, no? As I stay close to that definition of operational definition of diffuse. The two lobes are almost symmetrically enlarged pero walang nodules, walang bukol-bukol. Okay? And then anything that deviate from that definition, it's nodular goiter. Okay? Get it? Okay. The reason why I said almost symmetrically enlarged, kasi we've seen a lot of goiter, yung multiple colloid adenomatous goiter, halos kasing laki yung right and left, pero ang daming bukol. Na? Okay. So that's still MCAG, or multiple colloid adenomatous goiter. Na? Okay. So in this particular, when you have diffuse goiter, you start thinking of hyperthyroid muna. Very common kasi yan compared to hypo, more common. Okay. So then, kung may nakapang diffuse, baka hyperthyroid ito. So you start asking questions na directed to the possible hyperthyroidism. So ano mga questions tatanong ninyo? Or you can do some more focused physical examination to really check whether the patient is hyperthyroid or not. No? So you can look at the eye, di ba? Kung may exophthalmos siya o wala. Kung may exophthalmos, tapos diffuse ang goiter niya, most likely, from kanina, from 60% suspect siya just by palpating. Then, when you see exophthalmos, baka 90% yung degree of certainty that you're dealing with hyperthyroid. No? Kung wala siyang exophthalmos, okay, the absence of some findings does not negate it, right? Okay. So, anong hahanapin ninyo?
Pwede po magtanong kung naka-experience ng weight loss or kung madaling mainitan or yung feeling na parang kinakabakabahan, ganun po, for
Yeah.
hyperthyroidism.
Okay. Good. Okay. Good, Gabriel. Okay. Look, ask for more questions directed to what you're suspecting right now. No? Ganun ang approach. No? Okay. Huwag yung dekahon na gagawin niyo kung ano-ano, di ba? Okay. Focus talaga. No? Okay. Or the other one, a more practical one, kapaan niyo yung PE, as we know, signs are more reliable than symptoms. Yung symptoms are those answers that you get from the patients, which may not be as reliable as the physical findings, which are sign. Di ba? So, kanina exophthalmos, tinitingnan mo, wala. No? So, aside from asking the questions, ipalpate niyo yung pulse rate niya. Okay? If the pulse rate is tachycardic, more than 100, you would suspect hyperthyroid na. Okay? Okay? So you're not talking about cancer or no cancer ito, di ba? Okay? So kasi you were able to palpate a diffuse goiter. Okay? Okay? So can we leave that for a while? Punta tayo sa nodular. Doon tayo mag-focus na ngayon. Ha? Okay? So you have a patient who has a nodule on the left side. 3 centimeters. Then you have to describe it further. So you must describe, aside from the size does not connote anything. It does not say that it's malignant or benign. Okay, it's the other characteristics, which are the consistency of the mass, whether it's hard or not hard. Yun na lang. Kasi kung you can use other terms, but if you use soft, firm, it's equivalent to not hard. I did a research before. I asked clinicians, now even consultants, you palpate this mass, tell us. I get 10 consultants palpating the thyroid mass. And daming with so many classifications of consistency, soft, firm, hard. And this discordance is about 90%. Hindi siya nag-agree, kahit na consultants na. Kasi very subjective yung no? So once you tell them, can you just dichotomize it to hard, not hard? So, ang concordance became 80 to 90%. No? Okay? And what's more important in the yung mga masses in the body, no, it's whether it's hard. If it's hard, you start thinking of cancer. If it's not hard, pwedeng cancer, pwedeng hindi. Okay? Pero pag nag-agree na kayo na hard talaga yan, you suspect cancer. Okay? So, in this particular case, soft siya. Sabi natin yung doughy nyo is equivalent to soft, not hard. No? Okay? And then, the other parameter that the other characteristics that you look for is consistency. Okay? What I mean, nature of the mass, whether it's cystic or solid. Okay? Yan ang palaging nakakalimutan ng mga clinicians. No? Okay? If there's a mass, you try to determine whether it's cystic or solid. Huwag niyong kakalimutan yun. Ha? Importante yun. Okay? I suppose you have experience with your ultrasound report and other report. Now, when you have the word cystic there, they will usually say it's benign. Okay, majority will be benign. So if you palpate a breast mass which is cystic, most likely it's benign. If you palpated a thyroid mass which is cystic, a fluid, most likely it's colloid cyst. Okay. Okay. If it's cystic, most likely it's benign. Okay. But if it's solid, again, 50-50. You cannot still decide whether it's just based on the solidness of the mass. You cannot decide whether it's malignant or not malignant. Okay. Pero kung hard solid, then you start suspecting cancer. Kung soft solid, hindi pa rin. Okay. The other one is fixation of the mass. Yung sa inyo, mobile siya, di ba? Mobile siya. So, kung fix siya, you start suspecting cancer. Okay? Ano pa? Ano pang mga characteristics that you look for in a mass?
If there's pain pag pinapalpate.
Okay. Pain. So, just look for signs of signs of inflammations. Okay? Kung wala, most likely, you're not dealing with inflammatory conditions. Okay? Okay. Yung pain kasi very subjective yun eh. No? Okay. Even in that patient with 3 centimeters, no, although you just have to accept that the complaint of pain, but most likely usually non-specific siya. No? Okay? With 3 centimeters, usually hindi mo masakit yan eh, kahit na cancer siya. No? The moment it will become painful, kung malaking-malaki at nakadikit sa balat, no, then that's time na masakit. Okay? So subjective lang yung pain. No? Okay. So, but just the same you ask, no? If there's pain, but you you have to interpret the pain. If it's accompanied by redness is very important clue for inflammation. Okay? That's a physical sign. Kung may redness siya, then you suspect thyroiditis. Okay? Okay? We're talking about thyroid, di ba? Thyroiditis, di ba? Okay. So ano pa?
If
Sa thyroid,
movable po.
yung nasabi na natin yung Charlene, yung fixed mobile na. Okay. Then after that, you look for the neck nodes. Palpate the neck. Na? If there are neck nodes, you suspect cancer. If there are no neck nodes, doesn't rule out anything. Doesn't rule out the cancer. It might be in the early stage. No? Okay. Okay. So given all those data, you can come out with your diagnosis already. Muna. So 3 centimeter mass, which is movable, soft, not hard. Okay. Solitary, huh? Okay. No neck node. Okay. So you're dealing with benign or malignant, but which one will we put as number 1? No? So you still go by prevalence because there are some conditions that will have the same pattern, but the deciding point is the prevalence. Now, which one you will put as number 1? Okay. So to expound on this, para maintindihan niyo, before the advent of COVID, yung mga nararamdaman natin flu-like symptoms, diba? Flu-like symptoms. Okay. Usually, when you have flu-like symptoms, we say it's flu. Kung pumasok yung COVID, once you have flu-like symptoms, pero prevalent in COVID at that time, we shifted our diagnosis to COVID. Diba? Because of the prevalence at that time. No? Okay. Ngayon, this year, probably on the 4th year, sana hindi na, baka babalik na tayo sa flu. Kasi yung COVID, baka bumababa na. Diba? Okay. So that's an illustration of how you use the prevalent process. Now, how common is it occurring in that locality at a certain time? Okay. How common is it in the Philippines overall? Okay. Okay. So parang it could be that thyroid nodule could be thyroiditis, chronic thyroiditis, but it's not common as goiter, as or let's use the word, for the moment I'll use your word simple goiter now. Okay, so it's not as common as simple goiter, and it's not as common. It's not as common as papillary CA, no? Mas least common pa yung thyroiditis, chronic, no? Okay. Okay. So you're right in placing simple goiter because it's the most common. Okay. You have the pattern, but you cannot decide which is which, but you invoke prevalence. Okay. Pasok mo yung simple goiter as number 1, then CA number 2. Okay. Tentative siya. No? Okay. Okay. Then you try to quantify your degree of certainty na. No? How certain are you that you're dealing with thyroid CA, you're dealing with simple goiter? Probably it's about time that I discuss in terminology. No? Okay. Okay. So when you say ang daming nagbabago ngayon. Okay. I used to say that if there is a nodule, if it's cystic, I call it colloid cyst. Colloid cyst because it contains fluid, not cystic. Not. If it's a combination of solid and cystic, I call it colloid adenomatous nodule. Okay. Then if there are multiple 2 or 3 nodules, either on the same side of the thyroid lobe or both lobes, we call that MCAG, multiple colloid adenomatous goiter. Now, more specific. Now, we don't just call it simple goiter. Now, okay. Okay. So that's my present practice, but the other month, I discovered that they have new terminology again. They call it follicular nodular goiter. Okay, medyo nakakalito na. Follicular kasi follicular may connotation baka cancer siya, no? But still benign. Follicular nodular goiter or disease. No, they call it that way. No? Okay. So in this particular patient, it's a solitary nodule. It's soft. We say it's benign. It's a benign. You can call it colloid adenomatous nodule. Okay. Part of the family of simple goiter that you are using now. Okay. Okay. I'm just explaining the terminology. No? Okay. Then the other one is thyroid cancer. Okay. So you quantify the degree of certainty by trying to review again and again. Solitary kasi ito, baka cancer ito, no? Saka solid ito, walang cystic, no? Okay. So kung may cystic component yung mass, you can put your colloid nodule, you can put the degree of certainty to more than 90%. Okay? Pero kung solid siya, okay, bababaan mo na, no? Sabihin natin 80% ka na lang. Kasi solid wala siyang cystic area. Kung may cystic, malamang colloid nodule siya. No? Okay. Kaya lang mas mataas, mas malakas pa rin yung weight ng prevalence, di ba? Kaya natin nilagay sa una di ba? Okay. But if we have some findings that we'll try to contradict, we'll try to negate it, ibaba na lang yung degree of certainty. No? Okay. Okay. So the degree of certainty will be dependent on your experience, no? Okay. Nobody can fault you. Okay. As a doctor, kahit na generalist ka, you have to come out with some, stick out your neck as to the degree of certainty based on what you know. No? Then you just learn along the way. If you gather experience, palitan na ninyo. No? Okay. Okay. You ask all consultants, tanong mo yung degree of certainty nila, walang pareho-pareho, iba-iba. Di ba? Iba, mayabang, 100% certain ako. Okay? Yung iba naman with good experience, 90%, okay lang. Iba, 80%. Walang masyadong experience kahit na consultant level na sila. No? Okay. So nobody can fault them for that. No? Then basta the main thing is that they learn along the way. They gather more experience, they try to increase their degree of certainty, no? Okay, on certain diseases. No? Okay. So lagyan natin sa 80% kasi solid siya, di ba? Pero number 1 pa rin siya, colloid nodule. So the next thing to do is to decide what, remember, notice that I'm not invoking mga family history pa. Na-notice nyo? Hindi ko pinapasok ano. Okay. The other thing that you can ask, usually in practice, have you consulted another doctor? Very common kasi yan di ba? Do you have previous treatment? No? So in this particular patient, she has ultrasound. Nagawa. Di ba? Okay. Pero ang suggestion ko, ang my style is, I put it aside muna. I try to come out with my own clinical diagnosis without being influenced by the ultrasound report muna, based on my PE. No? Okay. Yung iba namang doktor, pasok na nila lahat. No? Okay lang yun. No? Pasok nila para madali. No? Okay. Now, kung iiwalay mo, colloid nodule 80%, no? So the next thing to decide, do you need paraclinical diagnostic procedure? Ang cut-off natin is, at the moment, ang suggestion ko, you won't see this in the literature. I just get it from experience, no? Kasi wala no? So when you say you're quite certain, when you say you're not quite certain, no? So I look for the literature, wala akong makita, but in practice, this is how we do. This is how we make decision, no? Just like in anything in life, di ba? I'm not certain of this. I'm quite sure, I'm not sure, di ba? Then I make a decision, di ba? Okay. In medicine, I try to make it more structured, pero wala rin ako makita, no? So I just use 90% as the cutoff. Kasi based on the mga research, kung 90% usually sure ka na. Yung mga laboratory exams, yung acceptable, usually 90% and above yan no? Accuracy, no? So 90% and above, certain ka na, no? Kung 99, mas maganda, no? Okay. Kung below 90, put it as not certain. Okay. So if kung 80 lang siya, you need a paraclinical diagnostic procedure. Okay. So what paraclinical diagnostic procedures that do I need for this patient? So you make a table of BRCA. No? Okay. The first column, anong ilalagay mo? Yung present ninyo, wag na niyong isama yung serum TSH, T4, because what you are considering whether it's cancer or not, di ba? You're not, ang pulse rate niya ilan?
$87 po, Doc.
87. That tachycardia. No? As a rule, if you have nodules and the pulse rate is normal, not tachycardic, it's non-toxic. It's not hyperthyroid. So you don't have to do the thyroid function test anymore. But to tell you, it's a sad thing in the Philippines and everywhere, it's the kahol. All thyroid patients will have TSH, T4, and T3. Okay, that's a sad state. No? Okay, which I cannot change also. No? Okay? Kasi kung di ka naman nagsususpect ng hyperthyroid or hypothyroid, why order for those things? Diba? Gastos lang yun, diba? And it use up the resources of the hospital and also of the country. Kaya most likely, baka hindi maging successful ang universal healthcare law, no? Kung di papalitan yung how doctors manage their patients. Kung saan maximalist sila, lahat gagawin, di ba? Dapat yung essential lang, minimalist, di ba? Yung kailangan lang, no? So if you're not suspecting hyperthyroid or hypothyroid, you don't have to do your T3, T4 or TSH. Di ba? Just stick to the other 3 that you mentioned there in your table. Sino nag-present nun? Sian, ikaw ba? Sian.
Kami po ni Shalom, yung
Okay.
sa
Kayla. Anong nilagay mo doon? Yung second.
radionuclide scan,
Scan and then ultrasound and then
and then
FEV.
FNAP.
Okay. So you compare the 3. No? So these are the 3 more common ones being done. There are others, but you just mentioned the more common ones. So in terms of benefit, no? Remember, you want to be more definite whether this is colloid adenomatous nodule or cancer. Tama? Okay. So which one, when you talk about definite, you look at the, if I remember your presentation, sa iyo ba yun? Indirect kasi yung sagot mo no? So you got to the point that kung gumawa ka ng FNAB, it's the direct way of getting an answer, di ba? Needle biopsy. You can do it, you can explain it that way. It's better than the other 2. The scan is an imaging procedure. The ultrasound is also an imaging procedure. So it's indirect, no? Okay. And then you can input another data based on experience. Bakit maraming gumagawa ng FNAB? Because it has 90% accuracy. At least 90%, no? Okay. How about the scan? Scan and also ultrasound. Pwedeng 90%. Scan baka lower. Scan will just tell you whether it's hot nodule or cold nodule. No? Kung cold nodule, that's most likely they will say that 80%, 80% are malignant. Diba? Okay. How about thyroid? Ultrasound. Sabihin natin 90%. Na? 90% yung ultrasound. Kasi kung wala kayong data, as a rule, 90% usually pwede na. No? Okay. But you have to look at the idiosyncrasies of all this data. So between ultrasound and needle biopsy, mas direct pa rin ang needle. So i-adjust mo ng konti. Mas mataas yung, mas lamang yung needle biopsy compared to the ultrasound. No? Okay. Okay. So if that be the case, just based on the benefit, ang priority mo, ang ipipiliin mo, if you were the one choosing, if you were the one recommending, will be a needle biopsy. Diba? Logical, diba? Okay. Then you have to input the others. Now yung other data, risk. So what are the risks for needle biopsy? No? Yung pain. Tama? Infection, bleeding. No? Okay. Sa scan, radiation. Okay. Which are acceptable, no? But you have to spell them out, no, to the patient, no? So yung scan may radiation, yung ultrasound halos wala, no? Maganda yung ultrasound, di ba? Okay. Very yung mga necrosis, very theoretical lang yon, no? Because sound waves baka mag-necrose yung tissues, pero regulated naman yung strength of the sound waves, no? Okay. So if you base it on the risk lang, lamang yung ultrasound. Pipiliin ng pasyente yung ultrasound, di ba? Kasi walang sakit, walang radiation, no? Okay. Pero i-combine mo yung dalawa, palagi mo i-combine yung benefit and risk, no? Okay. Huwag hiwalay, no? Combine mo. So, lamang yung needle biopsy with the pain, no? Pero lamang yung ultrasound in terms of no pain, pero mas mababa ang accuracy niya. So, you put priority on the accuracy, on the benefit. Na? Okay. Unless the patient will say, Doc, ayaw ko talaga magpa-needle biopsy. Masakit. No? So you don't have a choice but to give in to his what she prefers, no? Pa-ultrasound mo muna. Okay? Kasi yan ang patient-centered management. You listen to what they want muna. But at the same time, you try to educate them based on what you know. Okay? Gets? Okay? So ayaw niya. Okay, then look at the cost. Cost of the ultrasound probably is a private, you look at the cost of the private hospital, then before the government. Kasi kung mayroon kang alam na government, mas mura, papunta mo sa government, no? Okay. So ultrasound usually in the private hospital will cost you about 1.5, no? And then needle biopsy in the private hospital will cost you about 5,000, ganon, no? Okay. Okay. So again, you don't have the exact data, but you can initially hindi nyo alam, but may gut feel ka, mukhang mas mahal yung needle kasi kailangan pang may PF pa yan, no? Mga pathologists pa yan, di ba? Okay. So but along the way, as you experience a particular patient, tanungin mo magkano ginastos mo doon sa ultrasound mo para may data ka na input sa mo. Okay. Then availability. Okay. FNAB. Is it always available? Sa probinsya, ultrasound. Kaya importante yung may A kasi we don't know where you're going to practice di ba? Kung sa city, lahat available yan. Di ba? Pero kung nasa probinsya ka, no, paminsan walang ultrasound. Pero you can easily, if you know how to do FNAB, you can put in the needle right away. No, sandali lang naman yan. No? Okay, so you use FNAB. No? Then pag meron kang alam how to interpret on the gross level, kayang-kaya mo na yan. No? Okay. So after you give this information to the patient, you ask the patient to decide. Kung ayaw niyang mag-decide, no, she throws back the question to you, Doc, ano ba ang maganda para sa akin? Okay. So how do you answer that question? Anybody? How do we answer that question? Kasi usually binabato sa atin yan di ba? Angeline, San Miguel, try your best. Try it.
Siguro po we assess based on yung benefit sa patient and yung cost and availability niya. So, pipili po ba ako, Doc, among the listed?
Kasi binigay mo na yung data, lahat, di ba? Benefit, risk, cost, availability. No? Okay, sabihin natin available siya. Yung cost, you have the figure, the risk, and on, you have the benefit. So, you ask the patient, anong gusto ninyo? Pero sabi ng pasyente, Doc, kayong bahala. Anong palagay mo? Ang pinakamaganda sa akin?
Siguro po yung pinaka-direct na and yung, as mentioned before, yung greater than 90% yung accuracy, which is yung FNAB.
Okay, good. Okay. So initially, you base it on the most objective analysis. Okay, so data analysis. But you factor in their psychological makeup and then financial capability. Okay. So by this time, kahit mga 5 minutes ka na in the process of interviewing, evaluating the patient, meron ka ng inkling kasi nagtatanong-tanong ka rin as you do your physical exam, di ba? Okay. So alam mo na, makatakot na takot ito sa needle, ayaw niya talaga. So huwag mong pilitin. No? Sabi mo, baka mag-ultrasound na lang muna tayo. No? Okay. Pero kung okay sa kanya, no, magpa-needle biopsy direct na kung matapang siya, hindi siya natatakot, no? Okay. So you can do the needle biopsy already, no? Okay? So yan ang process. Okay? So ultrasound, pinili niya ultrasound. Let's go by the case. Nagpa-ultrasound siya. Anong lumabas sa ultrasound? Hypoechoic, only one lobe is involved, no? Okay. Thyroid's 4. Okay. and then ibangga mo sa clinical correlation, no? So solid talaga. So you bank on the solid, no? Yung thyroid score, opinion lang ng ano yan. Opinion ng ultrasonographer. You look at the description, no? Okay. Yung description, solid, walang cystic area, okay. Na-confirm yung ano mo, yung kanina, sabi ko, pag may solid siya, you tend to think more of cancer, no? I mean, kung solitary, isa lang, ha? Patapos solid, you think of cancer, no? Okay. Okay. So ngayon, pwede mo nang baliktarin, no? Okay. Pero kung lumabas sa ultrasound, may cystic component yung sa left lobe niya, now you stick to your colloid adenomatous nodule. Okay? So, sabihin natin, you advise the patient, do you need, Alexis, itong pasok ngayon, do you need a needle biopsy? No? Okay. So, i-explain mo ulit, may options po tayo, baka gusto niyo magpa-needle biopsy para sigurado, no? Para baka we can increase our no? Okay. So you give them the options again, needle biopsy, no? Benefit, risk, cost, availability, no? And then yung mga shortcomings of the needle biopsy, hindi siya 100%, katapos kamisan hemorrhagic smear ang lumalabas, no? Ganon. And then sabi ng pasyente, Doc, ayaw ko na. Kasi baka pag tinusok, baka kumalat yung cancer. Have you heard of that? Okay. Have you heard of that, yung mga belief ng mga lay people? Okay. Okay. It's a established na it's a reality. Yung mga pasyente na talagang ayaw yung pa-biopsy. Okay. Huwag mong pipilitin. No? Okay. Sige. Since based on the analysis ko, malamang malignant siya. No? But don't say completely 100% sure ako. It could still be benign, but we have to plan it according to what we saw right now, which is malignant. No? Okay? Okay, so pumayag siya magpa-opera. So, papa-opera na siya. So, you're planning on total or subtotal na thyroidectomy. Okay. So, yung total mo will be involving the left lobe and also the right lobe. No? Okay. So, during the operation, kasi wala kang needle biopsy, usually when we operate, when we open the skin, we do an intra-op evaluation. This is in contrast to physical exam. Physical exam is before the operation. But during the operation, kakapain pa rin namin. No? Okay? Titingnan namin kung talagang malignant or benign. Kung minsan may clue ka na eh. Kasi direct touching na yan. Direct palpation of the tumor. Di ba? Okay? So kung isuspetsa ng surgeon intraoperatively malignant, so na-confirm na malignant siya based on suspetsa kasi niya before the operation was malignant. So nakahanda na yung consent for total thyroidectomy or lobectomy kung sakali. No? Okay. So if the decision is to do total, then you do a total. If the decision is to do, kung benign siya, you can do a lobectomy. No, you can adjust during the operation. No? Okay? So, and then before the operation, you have to tell the patients what are the possible side effects of the operations, like hoarseness of voice, no? Hypocalcemia, particularly when you're going to do total thyroidectomy, then infection, bleeding, no? So tell them all these possibilities before the operation, and then ask them, what do you feel? Would you still want to go through the operation? Okay? So kung okay lang sa kanya, tuloy. But you have to tell them. No? So a surgeon do not promise no complications. Okay? So yun. So during the operations, total thyroidectomy, ginawa probably because malaki yung, okay, pros and cons based on the analysis that you gave. So the one who presented on the benefit risk cost sa treatment, ang manang isama yung RAI. RAI will come after. Na? RAI can come after. But during this time, priority mo is operation. So it's a decision, whether it's total or subtotal ang gagawin mo. No? Okay. So you compare the two. So based on your journal analysis, yung journal analysis nyo, which one is better o wala? Pareho lang.
Hindi po conclusive kapag sa size na we're dealing with 1 to 4 cm or 2 to 4 cm. In terms of overall survival, pareho lang po. Pero kung if we consider we want to be free of recurrence, definitely we go for total po. But that depends if gusto ng pasyente. Yung idea na wala na siyang thyroid and the idea na habang buhay siya thyroid replacement therapy, or you also have to consider risks, etc. So it depends on the patient then.
Okay. Kaya importante itong BRCA. Okay? Just before the operation, you explain everything. Based on the journal, sasabihin mo yung bigyan mo yung data under benefit. Na walang sinasabi. The journal says na walang difference, di ba? Okay. But you can expound further yung sa risk. No? Okay. So risk will be kung may local total thyroidectomy will have more risk for complications compared to a total lobectomy. Do you know that? Do you know that? Leah? Total thyroidectomy versus subtotal lobectomy.
Yes po.
Mas mataas ang risk ng total for complications. You know?
Yes po, because the nerves po, the adjacent structures po to the thyroid can be accidentally nicked or ano po, affected basically.
Lahat ng operation may risk, no? And then if you touch one side lang without touching the other side, wala kang risk on the other side kung di mo ginalaw, di ba? Sa subtotal. Pero kung total thyroidectomy, you have to touch on both sides, right and left side, di ba? Kaya mas mataas ang risk, di ba? So ang mga risk noon is particularly ang risk noon will be hypoparathyroid because these are very, very small structures which are not easy to preserve. No? Okay. Yung nerve medyo madali for surgeons. No? The recurrent laryngeal nerve is easier to preserve. No? Pero kung nakadikit sa tumor, then it has to be sacrificed. No? Okay. So you have to tell the patients this, kung total, mas mataas ang risk, sa total is lesser, no? Then ibabalance mo lang, the other factors na kung baka mag-recur dun sa, we cannot guarantee there will be no recurrence on the kung nag-subtotal siya, there will be recurrence on the remaining lobe, baka balikan pa kita, operahan pa kita ulit, di ba? Kung sinabi, ayoko na magpa-opera ulit, this will be my first and last. Okay, so the decision will be to do a total. Total na, di ba? And then, yung mga sinasabi na maraming controversies pa rin dyan. But I hope that paper of yours is 2020, no? 2020. This is a most recent meta-analysis. Tama, Rene? 2020 ito, di ba?
2020 po.
Yes po.
Very recent, di ba? Okay. So in the end, kasi if you look at the NCCN guidelines, mga gano'n, talagang dekahon sila, di ba? That you have to do this, do that, di ba? Okay. So eventually you have to factor in a lot of things, no? Then if you are dictated by yung mga mindset also of the doctors, di ba? Yung mindset kasi nag-influence din yun. Sabihin niya, kailangan i-total yan. Kaya yung PGH guidelines, they stick to the old one, di ba? Ito total nila kahit na maliit, di ba? Okay. So depending on the mindset of the yung iba naman mindset nila i-total na lang ninyo because bibigyan namin ng RAI post-op additional. Okay. So some physicians will think that dapat may REI after the operation. Kaya pinapatotal, okay, para mas madali, no? But for some physicians who subscribe to the total lobectomy lang, they don't need REI, so hindi na kailangan, no? Okay. So these are the things that you will encounter, mga challenges that actually sa inyo, on your part, sa tandaan na lang nyo, these are the options. Pero doon sa mga decision making, magulo yan. Na, magulo yan. It all depends on who's handling that patient. Na? Okay. So some would do total, subtotal, some would do total, then RAI, some would do the monitoring also. To facilitate monitoring, daw do a total thyroidectomy. Ganon. Na? Maraming ano yan. Okay. So the last one is so sabihin natin na-operan na ang lumabas. So which one is more common? Papillary, follicular?
PTC po.
Okay, papillary more
Papil
common. Okay. So yeah, pero pwede pa rin follicular ha kasi soft siya no? Soft. Kung soft siya, usually follicular no? Pwede pa rin no? Okay. So after the operation, walang problema, patient goes home, nag-total siya, you have to give your thyroid supplement, hormone supplement for life if it's total. No? If it's subtotal, you don't have to, but if you think that it can help suppress recurrence, then you can give no? A medical suppressive therapy in terms of levothyroxine, in terms of medical treatment. Then health promotions, restorations, you just advise them on how to monitor. Well, we don't know the cause, di ba? We don't know the cause of thyroid cancer. The general advice is just healthy diet, healthy lifestyle. No? Okay. Avoid the excessive radiation, no? Ganon. Okay. Then the other things that you have to advise them is surveillance, no? If it's thyroid cancer. So there are two schools of thoughts on surveillance. One is the symptom-based surveillance. The other one is a battery of tests of surveillance. No? Symptom-based surveillance means you just ask the patient how they feel, just ask them to monitor themselves. Kung meron silang nakakapang bukol dyan sa leg, then see you right away, or have a regular physical examination. I like your ATA. Sino na-present ng ATA guidelines? Okay, so Gabriel, no? First time I heard of it. Ano yung naka-ultrasound?
Nakalagay po na it will be monitoring the patient based on, wait lang, let me pull it up lang po. May categories, ay classification po based on yung thyroglobulin, antibody, tsaka thyroglobulin levels. Tapos, biochemical response, structural, tsaka indeterminate po. And if none talaga, excellent. Tapos meron po dun sa guidelines, may parang table po on like parameters, pero I didn't include it na kasi medyo mahaba po.
Na yung last slides mo, yung ATA, anong ATA recommendations?
Doc, they recommended not to use ultrasound screening for thyroid cancer because they didn't find any benefit po based on studies.
Okay. Ano pa isang recommendations? Like, ultrasound, that's for screening. No? Okay. Anyway, yung
Yes,
ako, kung minimalist ako, I usually just do a symptom-based surveillance without those thyroglobulin tests anymore. No? Okay. Kasi kung minsan nakakalito rin yung mga test na yan eh. You have to keep on repeating. No? So you just base it on symptom of the patient and then your sign surveillance. Basta may regular checkup with the physicians, palpating the neck. Okay. So a lot of times physicians, when they check up the patients, they don't usually palpate the neck. They just do a lot of laboratory tests like ultrasound, TSH, T4, thyroglobulin, etc. No? Okay. So that's the weakness of our system. No? Okay. So maraming maraming nagre-rely na ngayon sa mga technology without doing physical exam, no? Okay. So that's symptom-based surveillance. Okay. So, bakit kaya they don't recommend screening, using ultrasound for screening?
Doc, based on their rationale, the studies po kasi that they looked at, parang it didn't really have a difference whether or not nag-ultrasound ba sila or just the patient just reported that they felt the nodule. Or like symptoms-based basically po. So there was really not a significant difference between the two. So there's really no benefit
So when
with
you
or
say-
without
Yeah.
family history po.
So
Sorry.
when you say do not use ultrasound for screening, screening means wala siya. Parang kasi in the Philippines, marami nagpapa-ultrasound ng thyroid, di ba? Ang daming nakikita, no? To the point that matatakot ng mga pasyente, especially with the thyroid's reporting. Pag maraming nodules, iisa-isahin nila. Thyroid 3, thyroid 4, thyroid 2. Kadalasan merong isa, maging may thyroid 4. Pag may thyroid 4 na dyan, takot na yung pasyente. Okay, you end up with a biopsy or operations. Unlike before the advent of the thyroids, now usually when there are multiple nodules, right away we say that 98% chance that this is multiple colloid adenomatous goiter. Di kahuna. No? We just observe the patient. No? Ngayon, with that thyroid's reporting, iniisa-isa ng mga radiologists. Kaya may lumalabas na T4. Pag may T4 na dyan, okay, kadalasan matatrap na yung physician as well as the patient. Yung pasyente matatakot, yung doctor will tend to say, para sigurado, opera, i-biopsy na natin, opera na natin. Compared to the younger times, mga old times before, walang mga thyroids 4. No? Okay. So, any questions? So I have explained to you the whole process, my patient management process, using my framework. No? Which do you think it can be done? We can achieve the same results, di ba? In 15 minutes.
Actually, Doc, we do appreciate the framework nga po. Kasi I feel like it would have been useful also if it had been introduced sa amin nung LU4. Because like with yours pa, it's more stepwise now. We start muna with what we see based sa signs symptoms. Then we decide muna sa diagnostics. And after that, tsaka tayo may more or less final diagnosis instead of like the usual po ng LU4 na primary impression and differentials agad. Tapos magkasama na yung clinical and possible paraclinical findings.
Yeah, okay.
Doc, I also appreciate na dalawa lang po yung pinasulat yung differential sa amin. Kasi doon po humahaba yung discussions minsan tapos hindi naman pala like priority yung iba. So medyo mas derail yung discussion from the main ideas compared to yung what we did today. At least we're focusing on two main lang po.
Yeah, okay. Thank you. Any more comments?
Sir, the BRCA approach to selecting screening and treatment modalities helps us further narrow down our choices as opposed to just knowing what possible treatments are for the patient. It further helps to know which are the feasible treatment modalities are for a specific clinical scenario.
Okay. So yung mga clinical practice guidelines, they don't input the cost availability. Tama? So which we need when we manage a patient, not only here in Metro Manila, no, but also in the provinces. No? Availability of factor is very important. No? Okay. So any more comment? Angelica?
I really appreciate din po na hiwalay po yung clinical at paraclinical kasi as nandito sa case namin, nagpalit siya from yung primary and yung secondary, nagbaliktad siya after siya nagkaroon ng paraclinical diagnostics. So, different yung considerations namin from history and PE and then after yung ultrasound nga po.
Okay. So there, okay, I want to comment, additional comment. There's no such thing as a wrong diagnosis or misdiagnosis. As long as you are vigilant, you can change it anytime. Okay? Wag mo lang pabayaan kasi kumisan, ay tapos ito yung diagnosis ko tapos na. No? You have to be vigilant in monitoring the correctness of your diagnosis. The only time that you can say, tapos na yung responsibility mo, kung umalis na yung pasyente sa iyo. But the moment the patient is still going back to you, you keep on following up the patient hanggang makuha mo kung talagang tama yung diagnosis mo or not. No? Okay. Pag binitawan mo at sinabi mo huwag ka na magpa-check up sa akin, it turned out na mali ka, sometimes they can sue you. No? Kasi when they go to another doctor, sabi, eh, mali ang binigay sa iyo ng diagnosis ng ano. No? So initially, you can be wrong, but as I said, you are never 100% sure. You have to accept that. So you keep on monitoring until na makuha mo yung tama. No? Okay. Change it right away. Pwede mong palitan. No? Okay. So any more comment? Leah, anything?
Thank you po, Doc, because super high yield pa yung SGD. Yeah, I really like that we went through everything for the physical exam because I feel like that's something I kind of lack as of now po. And I think it goes the same po for everyone kasi po we're just about to rotate na po in the OPD. So stuff like this po would be really helpful when we're actually in front of patients na po. And it's subjective sometimes po pag PE, as you said po earlier. So this would help sort of make things clearer.
Okay. Good. So integrate na ninyo. You come out with this process and then ibangga niyo yung pathophysiology. Tutugma naman yan di ba? Okay. So just remember yung cancer. Kung theoretical yung discussion mo, mahirap din unahin mo na lang yung process, di ba? Because we know that cancer in its early stage will not present with all those classical signs of symptoms of invasiveness or spread, di ba? Negative pa yan, mga findings, di ba? Okay, so you have to remember that. Kasi usually pinasabi sa discussion sa pathophysiology yung full spectrum ng disease, di ba? Okay, but we know that when dealing with a patient, we catch them at a certain stage. No? Negative pa yung mga nodes, but if you let time passes by, then lalabas na yun, di ba? Okay. Okay, any more? Wala na magsasalita. Okay. So, meron pa tayong 5 minutes. Okay. So, if there are no more questions.
Doc?
Yeah.
This is not a question po. But our group prepared a little something for you po to show our appreciation po for this high yield SGD po.
Paano niyo nalaman high yield, magiging high yield ito?
Kakagawa lang po, Doc.
Yes po.
Kakagawa lang.
Kagagawa lang po.
Okay. May ginawa kayo. Akala ko bibigay niyo sa akin in terms of the Zoom.
Opo, via Zoom na po. Wait lang po. I-share screen po. Wait lang po. Ito po, Doc. Wait lang po. Ito po, Doc. Sorry po. Paano ba to? So, ito po yung pinrepare ng group po namin.
Okay.
So, UPCM 2026 LU5 Group 80 presents this certificate of appreciation to Reynaldo O. Hoson, MD, for high-yield discussion on thyroid carcinoma as part of the OS217 Oncology module, given this 15th day of September 2023, signed by me, group facilitator, and my group mates po.
Okay.
Thank you, Doc.
Thank you. Thank you very much.
Thank you so much po, Doc.
Thank you, Doc.
Sige po.
So kung di high yield, hindi yung bibigay ito sa akin.
Bibigay pa rin po, Doc.
Alam po na high yield talaga.
Okay.
Yes po.
Okay, thank you very much. I hope you can share this kasi I don't do this often, di ba? Kung na-assign, may group na-assign lang sa akin, then I share this. No? Okay. So you can share this with your other group mates, no? With your other classmates. No? So let's have a group picture taking. Pwede?
Doc. Yes po, Doc. I'll take the picture po. Okay po. Okay. Ready? 1, 2, 3, smile. Okay, another one po. 1, 2, 3, smile. Okay na po, Doc.
Okay. Now, I have a, sandali ha, share ko lang yung screen. Read added, ano, yung parang, what do you call that? May handouts ako that can reinforce this learning. Sandali ha. On thyroid ha. I'll put it in the chat box. Clinical diagnosis of thyroid disorder, a self-instructional program. Basahin na lang ninyo. This is still up today, very up, which I still use in my practice. No? Okay. Basahin na lang ninyo. Then, then can you answer this ulit sinabi ko. I'll just give you the link. No? So, madali lang ito. No? 100 questions lang. No? True and false. Ganon. No? Okay. So try to get a perfect score, then I'll give you a certificate. So this is in exchange tayo. You give me a certificate, I'll give you a certificate also. Okay. Ang certificate will be something like this. So take a look at this itong web page nito, wherein I put all my documentations of my SGB. Okay, not only for LU5, LU7, gano'n, na LU4. No? Okay, then, okay, nakopy na niya. So ito, no? LU5 receptorial. I will put all this, our proceedings here. Ito yung example of the certificates that you will get. No? Okay. Nakikita niyo? Nakita niyo?
Yes po, Doc.
Okay. So, okay. So, tapos na tayo. So, you can contact me anytime, no? Through Facebook, through my, I'll give you my number, cell phone number, 9180. Yan, no? So you can contact me anytime if you need some more, if you need to have questions answered by me. Okay. So there are no more questions. Let's call it a day. At least di tayo lumampas ng 4 o'clock. Okay?
Thank you so much, Doc. Thank you
Bye-bye.
po.
Thank you po.
Thank you.
Thank you,
So
Doc.
much,
Salamat
Doc.
po.
You will
Thank
send
you
me this.
po.
Thank you
Erling,
po.
you sent me the certificate.
Yes po, Doc. Doc, sa Facebook na lang po ba or email po?
Sige, Facebook or email. My email is
R.O. Hoson po, Doc?
2000
At Yahoo.
at 2001.
2000. R.O. Hoson 2000. Ay, okay pa. Thank you, Doc.
Okay.
Thank you.
Thank you.
Thank you po.
Thank you. See you around.
Bye.
Thank you so much,
See you around.
Doc.
Bye-bye.
Thank you po.
Retirement po.